Good afternoon and good morning for the rest of the US outside of the East Coast. My name is Ashley Valentine, and welcome to our 2022 Six Cells coverage for SCD Summit. Next slide. Great. So, as many of you know, I'm co-founder and president of Six Cells, and our other co-founder is Marcus Valentine. Marcus lived with sickle cell disease for 36 years. He passed away in 2020, and together we had a vision to elevate the voices of the sickle cell disease community in order to ensure change for this population, improve access and quality of care, and also to change hearts and minds. Next slide. So Marcus was an incredible human, an incredible spirit, and he truly just wanted to ensure that everyone that he had known with sickle cell disease could have access to quality of care like him. We also wanted to highlight that there's such resilience in a community like the sickle cell disease space. And so our goal is to really educate through the voices of this patient population and share their stories of resilience. And that's what we hope to do here today. Next slide. So, our mission and our vision is to ignite public interest in sickle cell disease, humanize this condition in order to inspire change, influence decision makers, drive research and policy change, and also empower the sickle cell disease community, patients, caregivers, friends, and families to use their voice and share their stories and know that they're not alone. Next slide. So we have a very packed day. We're going to cover lots, but we're going to get through, and we hope that everyone can learn something and take away something positive from today. So we'll later hear in a moment from our keynote. We'll also hear about the state of access and Medicaid for prescription drugs for sickle cell disease. We'll look at how to improve equity and affordability of sickle cell disease. Next slide. We'll also hear from a panel of sickle cell warriors and caregivers, and we'll close out the meeting today about the managed care approach for sickle cell disease. Next slide. So we'd like to thank all of our sponsors. We couldn't have done this without you. Next slide. And now we have the great honor to introduce our keynote, Amar Zaidi. Dr. Amar Zaidi is a pediatric hematologist who spent the last several years at the Children's Hospital of Michigan, where he helped care for over 800 patients with sickle cell disease. He currently serves as a medical director, clinical development for Agios Pharmaceuticals. Along with numerous publications and clinical trial experience, he has worked tirelessly as an advocate for sickle cell disease patients, fueled by a belief that medical misinformation and disinformation steadily contributes to poor outcomes in sickle cell disease patients. He co-founded and hosts the sickle cell educational podcast Cheat Codes and has been an advocate for social media as a tool for patient and physician education. He currently serves as the chair of the Hematology Anti-Racism Task Force for the American Society of Hematology and the chair of the board for the Sickle Cell Reproductive Health Directive. Without further ado, Amar, I'll hand it over to you.
Thanks, Ashley. Can you hear me okay?
Yes, you sound wonderful.
Awesome. Well, first of all, thank you for the kind introduction. And I've got to say, it's just such an honor and privilege to be here with Six Cells at this coverage for SCD Summit. I'm so proud of the work that Six Cells does, and so happy to be able to partner for this presentation, where we're going to talk a little bit about something I feel very strongly about, which is rehumanizing sickle cell care together. Let's go to the next the next slide, sorry. And we can go one more. So my disclosures are listed here, the most important one being that I am an employee of Agios Pharmaceuticals, and the opinions and positions expressed in this presentation are my views and don't necessarily reflect those of the company. We can go to the next slide. The story of sickle cell disease is told proudly in medical schools and history books, particularly the story of sickle cell disease in the United States. The story goes sort of like this. In 1904, a ship called the SS Sirens docked in New York and unloaded a passenger from Grenada who had come to further his studies in dentistry in Chicago. And this passenger, once he disembarked in New York, noticed an ulcer, something he had noticed on himself many times before, but wasn't really sure why. He sought care got the care he needed, and headed over to Chicago to start his dentistry studies. When he gets to Chicago, the patient's feeling worse. He's feverish, he's feeling weak, his eyes have turned yellow, he's having pain. He's felt this before. He walks into the Presbyterian Hospital in Chicago in 1904, and something amazing happens. Of course, something amazing because it's 1904, but I would say even in 2022, it would be amazing. He's met by the intern, Ernest Irons, who notices that something is wrong with this patient, and he does something spectacular. He orders all the right tests and even some extra ones. He notices that this patient is anemic, and you see in the red box here, notices when he's looking at this extra test called a peripheral smear, he's noticing that the size of these red blood cells is irregular, and that the shape of these red blood cells is irregular, and that there are these long sort of filament-like structures on the peripheral blood smear. He had never seen this before. Ernest Irons wasn't sure what he was looking at. We can go to the next slide. So they follow this patient known as Walter Clement Knoll, the protagonist in Western medical literature of the sickle cell disease story. And they describe his case in 1910. And they say these are peculiar, elongated, sickle-shaped red blood cells in a case of severe anemia. The way that this case report is written is that this case is reported because of unusual blood findings, no duplicate of which I have ever seen. This first sentence is interesting, and certainly a blood smear of a sickle cell patient had not been seen to that date. But the story of sickle cell disease did not start in 1904 on the shores of New York. If we go to the next slide, we know that the sickle cell disease story in the United States of America is not glorious. It starts in 1619 with a ship called the White Lion, and many ships after that bring hundreds of thousands of African origin slaves to the eastern coast of the United States. That's where the story of sickle cell disease starts here in this country. And it's important to acknowledge because when we go into the Western medical literature a little bit more deeply on the next slide, we note that the patients that are described by people like Scope in 1783, where he says, they're patients who look pale and yellow and prematurely old and have fevers when he's visiting the Carolinas. And the case of Robert Levy's runaway slave, caught, convicted, executed, then on autopsy found to have leg ulcers and abscess spleen. These are the origins of sickle cell disease in the United States of America. It's a story that starts with generational trauma. It's a story that's embedded in structural racism. Let's go to the next slide. What I want to talk about today is this systematic dehumanization of sickle cell disease patients as they live their lives in confines of this structural racist society that they're facing. And I want to say that all of us, everybody, is responsible for its persistence. But the silver lining here is that we're all going to be part of its dismantling, and we are going to dismantle it one step at a time. Let's go to the next slide. We already know that in a vulnerable population that comes with as much generational trauma as the Black American population does, knowing that the civil rights movement really sort of set the tone for how Black Americans should be appropriately treated just in 1975, not 40 years ago. We can expect that a healthcare system that's built to deliver care for Black Americans is not mature. It's not ready. It doesn't care enough. And that is seen in every realm of healthcare. We see it in cardiovascular disease, where Black patients are more likely to develop and more likely to die from heart disease. They're less likely to get life-saving measures. In kidney disease, we know that Black patients get more dialysis and less organ transplant. The National Cancer Institute tells us, hey, when Black people and white people get the same care in cancer, they survive the same. But we know that's not true because Black patients get diagnosed later, they get treated less, they have less intervention. And on the next slide, you'll see that this spills into things like obesity and diabetes. This spills into things like stroke and high blood pressure. It spills into things like colorectal cancer and infant mortality, low birth weight. In fact, The only thing that Black patients are more likely to get than white patients are antipsychotic medications and limb amputations. That's the state of American healthcare in vulnerable populations like this one. Let's go to the next slide. And we saw this. We saw this with COVID-19, right? When we look at vulnerable populations like the indigenous population, the Black American population, the Latinx population, you see that the rates of hospitalization and the rates of death are far greater. They're multiplied, they're amplified in these populations because our healthcare system is not built to take care of these individuals in the way it is for others, right? And the amazing part of this is as this was happening, there were all these stories about we wonder why. We wonder why the Black population is disproportionately dying. It's amazing how out of touch sometimes we can be with what we've done to this vulnerable population. But let's take it back just a little bit more. Let's get back to sickle cell disease. So let's go to the next slide. Let's talk about this man here, the Nobel laureate, Dr. Linus Pauling. You see, that glorious story of sickle cell disease in the United States of America starts in 1904 as the SS Syrians docks in New York. And then in 1949, the next big landmark comes where Linus Pauling says, I've got it. I know that sickle cell disease is caused by an abnormal hemoglobin molecule. There's a mutated hemoglobin molecule. He, of course, wins the Nobel Prize in 1949, describes sickle cell disease as a molecular disease. And this, of course, is the foundational building block upon which scientific discourse now goes. This is where everything builds from the thought process of Dr. Linus Pauling. Let's go to the next slide. Well, Dr. Linus Pauling had good moments and bad ones too. What's shown here is a newspaper clipping 2 years after he described sickle cell disease, where he's talking about bad genes and marriage. And he says, I agree, we should keep these carriers from marrying one another. And I've advised, not entirely joking, that individuals should have tattooed on their foreheads symbols for the defective genes they carry, or it would be better to tattoo symbols in Braille on their abdomen. This is the thought process of a man whose thinking is the basis upon which we've built the care for sickle cell disease patients. The rest of the story is unpredictable then, right? We know where this is going. If we go to the next slide, we know the data. We know what the data is. The data tells us that patients with sickle cell disease wait 25% longer in emergency rooms. We know they wait longer for their first pain medication despite guidelines telling them that they need to get their pain medication within 1 hour. We know that sickle cell patients are stigmatized and shunned by physicians, by hospitals, by insurance companies, by the community. We know they're not believed when they say they're in pain. We know that pain scores reported by non-sickle cell patients get believed far, far greater. We know that there's disparate research funding. We know that cystic fibrosis gets 27 times the funding that sickle cell disease does. And we know that we don't have the appropriate management for pain happening in hospitals all around the country. We know that this disease is not being managed the way it needs to be, just like every other realm of healthcare in the Black population. Let's go to the next slide. So, of course, the survival in sickle cell disease echoes a history of not caring about Black health in this country. Shown here are two graphs in light purple, the mortality curve in 1979, and dark purple, the mortality curve in 2006. We see that in 1979, there's a sort of peak of mortality in children 5 years of age and less with sickle cell disease that's gone away in 2006. It's amazing it's gone away, right? And what that took was people caring. It took people like the ones in this room today to say, you know what? Let's change things. Let's start newborn screening. Let's start prophylactic penicillin. Let's give advanced vaccinations. Let's start comprehensive sickle cell care centers. It's amazing how effort and work, when done in a humanistic way, can change outcomes. But we see that we failed the adult population. We have failed the adult sickle cell population. The adults with sickle cell disease in our country to this day are dying 3 decades earlier than they should be. This is the truth of sickle cell disease right now. Let's go to the next slide. The biology of sickle cell disease is simultaneously simple and complex. What this means is all of us know that the basic biology of sickle cell disease is that crescent moon misshapen red blood cell, right? But there's so much nuance to that, right? There's the science of what happens when red blood cells spill the contents that are meant to be inside of them out into a bloodstream. What happens when multicellular clusters block forward blood flow? What happens to the endothelium, the blood vessels? What happens to an inflammatory system that's an overdrive? What happens to these things? This is very complicated and manifests differently in all sickle cell patients. So, yes, one molecular defect, but a myriad of outcomes, a myriad of complications that presents. But the loudest of these complications, and the one that gets the most attention, of course, is acute pain. Let's go to the next slide. Of course, acute pain gets a lot of attention because it causes a lot of healthcare resource utilization. According to the SWAY data recently published by Osunkwo, we know that whether you're in the United States, a high income country, or a low middle income country, most sickle cell patients are having at least two and 11, sometimes 11 or more vaso-occlusive crises that are sort of happening in a span of a year. This is a big problem in sickle cell disease. And let's go to the next slide. And of course, it's a costly problem. This is a problem that makes patients feel terrible. It makes patients feel not seen. It makes healthcare systems bleed money because each VOC that happens in healthcare settings, particularly those in the inpatient setting, can cost a median of upwards of $11,000 and on average about $5,000. So if you imagine each sickle cell patient having at least two VOCs, you can see this sort of adding up pretty quickly here. Let's go to the next slide. So what we see is annual medical costs of about $34,000 and predictably patients having 3 episodes or more driving cost and healthcare utilization. Let's go to the next slide. But the problem is that pain is really complicated. You see, this is the tip of the iceberg that we're talking about. Healthcare utilization in sickle cell disease is the tip of the iceberg. That's what everyone cares about. That's what healthcare systems care about. That's what insurance companies care about. That's what patients care about because it's disruptive to life. It's disruptive to the healthcare system. It's disruptive to their life. It's a challenging complication. But the truth of what patients deal with is much larger than the tip of the iceberg. It's the submerged part of the iceberg that no one sees. Yes, it's pain. 75% of all pain happens in the patient's home. But it's the non-pain, right? It's the stigma and the bias. It's the organ damage and the, having to navigate a healthcare system built to suppress you. Let's go to the next slide. So what I want to say to you today is the biggest lie ever told is that sickle cell disease is a disease of only pain. It's not. It's actually a disease of decreased life expectancy. It's a disease of accelerated aging and a disease of organ failure. Sickle cell patients die because their organs shut down, their organs fail them. This is the truth about sickle cell disease. And of course, when you think about sickle cell disease with that broad spectrum, let's go to the next slide. You see the direct economic burden of sickle cell disease becomes substantial. The lifetime care costs of sickle cell disease per patient is $1.7 million, which is 900% higher than those without sickle cell disease. You see that the out of pocket estimates of cost to sickle cell disease patients is $42,000, which is almost 300% more than non sickle cell patients. And of course, payers put out 95% of these costs, and the rest comes from patients. But even that bit that comes from patients, the annual out of pocket burden of sickle cell disease amounts to about 3% of the median household income for Black Americans who have already suffered from this generational structural sort of violence that they've been victims of, whose income and assets is already far below the majority population. This is a problem for everybody. This is a problem for payers. This is a problem for patients and caregivers. This is all of us combined in this. Let's go to the next slide. You can imagine then the psychosocial toll on patients and caregivers dealing with sickle cell disease. Of course, it impacts their emotional well being. Of course, they feel stressed. They worry about who's going to take care of them. Of course, they worry about getting worse. They worry about dying. They feel depressed. And of course, they feel helpless because who are the helpers? Where are they? Where have they been? We've been waiting for helpers for a long time. Let's go to the next slide. So, the structural factors of systemic injustices and institutionalized racism, the historical framework upon which the system is propped up, drives a lot of these issues. Let's go to the next slide. There's also a cost of missed work and school opportunities, right? There's a cost of missed opportunities in general. Patients can't perform at work, they can't perform at school. This is a problematic sort of long-term cycle that is very difficult to break. And we really don't know the cost of this. And Sick Cells has worked hard to try to make us understand that this is a big part of the sickle cell burden. Let's go to the next slide. The truth here, my friends, is that sickle cell disease patients are drowning. Caregivers are drowning. They're up against a healthcare system that doesn't want them. They can't find doctors who care. They have insurance coverage issues that limit their ability to find what they need, and a community that has largely ignored them. This is a big problem. Let's go to the next slide. Ideas are good, and we have lots of them. There are ideas for care models, but can we fund it? Let's go to the next slide. There's a robust pipeline of therapies, curative, non-curative. There's so many companies and a spotlight on sickle cell disease therapies right now, but can the patients get them? Will they enroll in clinical trials? And if drugs get approved, can patients access them? Will doctors write prescriptions? And if they do write prescriptions, will those prescriptions get approved, or are we going to have to navigate through this maze of prior authorizations and care guidelines that are seemingly random? Let's go to the next slide. We have a blueprint to better days given to us by the National Academy of Sciences, but can we build it? Can we get to a goal of healthy, productive lives for individuals with sickle cell disease? Can we address the research gaps and the funding limitations? Can we address the advocacy needs? It's a big pull ahead of us. Let's go to the next slide. We started with the story of the African continent and the transatlantic slave trade, and I want to end this talk going back to the African continent and talking about this concept known as Ubuntu, which is a profound sense that we're human and only through the humanity of others we become human. And that if we're to accomplish anything in this world, it will be in equal measure due to work and achievement of others around us. Simply, Ubuntu is summarized in the phrase, I am what I am because of who we all are. Sickle cell patients are what they are today because of the rest of us. The dehumanized care that they're receiving is on our shoulders as counterparts in this society. So today I want you to ask yourself, who are you for sickle cell disease patients? How are you influencing their current existence, and how will you change that going forward? Because it's only through your humanity that we can rehumanize care for patients with sickle cell disease. And with that, I thank you for your time and attention.
Great. Thank you so much, Dr. Zaidi. And for the crowd listening, we do have about 6 minutes for a few questions. So you can feel free to type any questions into the comments section and our team will flag them and I can see them. But just to get us started here, first of all, thank you so much for the history of how we got here in the medical system of sickle cell disease. It is pretty complex how we got here, but there's almost a clear path of the way sickle cell was diagnosed and treated in medicine and the path of care given today. Um, so just curious, when you were in medical school, what were you taught about sickle cell disease?
Nothing. One paragraph, right? It was, hey, look at this cool disease. There's one letter changed in the DNA, one protein changed in one amino acid changed, and it causes all of these problems. And it's autosomal recessive. This is the disease that is the example of autosomal recessive inheritance. And that's about it. That's about it. And I was
Hmm.
fortunate that I got to go to medical school in the West Indies where I got to see patients with sickle cell disease. But theoretical sickle cell knowledge is non existent. What I've learned from what I've learned about sickle cell disease, I've learned by being in rooms with patients.
Okay, that's helpful because that was my next question. So, if there isn't a lot being taught formally in medical school or in pharmacy school, how can someone who is working in the medical clinical space learn about sickle cell disease?
Yeah, so I think that we have a few problems there, right? So the first is there's a difference between, I guess the goal is compassionate and competent care, right? And if you can get to competent care by reading, right? You can get to competent care by forcing yourself to read, but compassionate care is a little bit different. And I think that you need both to be successful as a sickle cell physician. For me, it took being in the presence of patients, right? For me, it took being around patients and individuating them outside of their disease. I think what we need to do is talk very openly to physicians, particularly those who aren't in communities where sickle cell disease is prevalent, right? I think that that's where trouble really strikes the community, right? Is running into physicians that lack competency and compassion. Often you'll find physicians who are competent but not compassionate, and those are usually in cities where there are a lot of sickle cell patients. But of course, the golden egg here is going to be the physician that's both competent and compassionate, and I don't think there's an easy road there, Ashley.
Right, that makes sense. So, you talked a lot about the cost, the financial burden to the patients, the financial burden to the healthcare system, but then you also highlighted that sickle cell could cost up to almost $2 million over the lifetime of someone who is dying 30 years earlier than the general population. Just thinking about those different buckets, what contributes to the high cost of care, the high financial burden to families? That's two questions in one.
Yeah, I think the high cost of care, I mean, to date has been really driven by inpatient VOC admissions, right? With then sometimes these catastrophic events like acute chest syndrome and stroke, chronic transfusion programs, chelation therapy, right? This has really been the driver of cost in the United States. I think we're now getting into an age where we're starting to ask for insurance companies to make an upfront investment, right? We're saying, hey,
Mhm.
we've got these drugs now that are FDA approved, and they're going to cost a little bit now, but they're going to save you in the long term, right? And I think that that is a mindset change. Though it will temporarily increase costs, I think long term it will pay off, and you will see that $1.7 million number decline. The other question you asked is really about costs to families, and I think that's one that, Ashley, you've put a lot of thought into about how to measure, right? And it's very difficult to measure the cost of missed opportunity. It really is. You can talk about, sickle cell families on average or patients on average, according to Sway, miss about 8 hours of work per work week. That's one day of work, right? You can do the simple math on that, but that also leads to lack of being able to get promoted, move forward in your career, do other things, right? So the cumulative cost to families, I think, is unimaginable to some of us. I don't think it's easily measurable, and I think it is equally crippling and catastrophic.
Yeah, yeah, definitely. I saw that a lot in my family too. So when that one person was sick, it impacted everyone all around, not only during the admission, but before and after. So we have one question, and this is going to be our last question. Do you have a story from or an experience with a sickle cell warrior that has stuck with you?
That's hard to pick one story that sticks with me, but I can tell you that being a physician that's been at the bedside to tell a family about a new diagnosis of sickle cell disease with a
Yeah.
newborn screen, and being at bedside with families that have lost warriors in pediatrics, there's not a day that goes by where I don't think about the patients I've lost at ages 8, 11, 14, 17 years old. And I think that that keeps me in this space. It's that really that family going through that moment, the strength you see in some of those families. Ashley, you know this well. The way that families come alive around moments of misery and death is the most inspirational thing that I've seen. And it's something that truly other disease spaces really can glean insight from. It's certainly something that sticks with me.
Yeah, that's a great answer. I'm biased. I believe the sickle cell disease community is very, very special, but you definitely just supported that too. Well, we are out of time. Thank you so much for sharing that story of sickle cell disease, your perspective. And for everyone to know, you can find a Mercedes podcast, Cheat Codes. I'm on an episode, and it is a great educational podcast that does feature a lot of wonderful people from the sickle cell disease community. Well, thank you so much, Amar.
Thanks, Ashley, for having me. I appreciate it.
Wonderful. Now, if we can go to the next slide, I'm going to turn it over to Six Program Manager, Emma Endelson.
Hi, Ashley. Thank you so much. Good afternoon, everyone, though I'm still in morning time, so good morning to everyone who's west of the East Coast. I'm here today to talk about the state of access in Medicaid, and this is the Six L's report out of a recent Medicaid research project that we just concluded. And I'm really excited to get into what this project was all about, some of our key findings, touch on some of our recommendations, and let you know a little bit more about where to find the complete report. So we can go ahead and start the slides. So we wanted to start with a little background about Medicaid and why we decided to do this research project. So Medicaid, as we all know, is a key source of insurance coverage for individuals with sickle cell disease. You'll see down below that a recent Medicaid CHIP and CHIP report card published in 2020 using 2017 data reported that at least 40,000 sickle cell disease patients rely on Medicaid as their primary source of insurance. But we know that this is, we know pretty easily that this is an undercount because this only accounts really for long-term coverage and doesn't take into account folks who are using Medicaid as short-term coverage. So when you start adding folks who use Medicaid for just a limited period of time, this number gets much higher. And we know that it's at least over 50% of those living with sickle cell are relying on Medicaid as their primary source of insurance. Another important aspect of this is that 40% of folks with sickle cell meet the medical condition criteria for publicly funded disability benefits. This is really key because this means that they're relying on this as a long-term form of coverage, and this is really important from the payer perspective. So let's go ahead and advance to the next slide, and I'll get a little bit more into the report itself. So with this background of Medicaid, understanding the role that Medicaid plays in covering the needs of individuals with sickle cell is becoming more and more important. This has been something that Six L's has focused on for a long time, something the community has focused on for a long time, but we are definitely trying to push this even more into the conversation surrounding sickle cell. So as many of you know, there is no current national sickle cell surveillance system. There are some national agencies, but the data that's being collected is not in every single state. So as new treatments emerge, this brings a lot of questions of appropriate coverage and reimbursement, as well as expected outcomes, to the forefront of these conversations. So you can see on the right-hand side here a couple infographics that we pulled from that 2017 report that I mentioned. So this is from the Sickle Cell Report Card, Medicaid and CHIP. This was one of the first reports on utilization, but it's not comprehensive, and really only offers a glimpse into the type of data that we need to have in order to establish this conversation about coverage and access. But this really gets at why our Medicaid project was so important to us and why we felt that it needed to be done. We felt that there was a big need for this data that establishes the baseline for conversations about current and emerging treatments and how folks in the sickle cell community are accessing and getting coverage for them. So as you can see on the right, there are, 78% of beneficiaries live with sickle cell, and 34% without sickle cell are accessing the emergency department at least once a year. So we know that those with sickle cell are in the ED much more often than Medicaid beneficiaries without sickle cell. If you look at the graphic on the bottom, that is honing in on hydroxyurea usage. So you can see the top explores children, the bottom explores the adult population. this is just sort of a basic glimpse into the type of data that we want across the states, across all sickle cell treatments and emerging therapies. Let's go ahead and advance to the next slide. So about our Medicaid access and landscape review, this is just sort of a project overview. It started in April 2022 when we decided to conduct a survey of decision makers at state Medicaid programs. This survey had findings that were supplemented with an environmental scan to look at what access and coverage looks like across the states. In order to do this, we partnered with Avalier Health to to do the environmental scan, to conduct the survey, and to write the report. And the report is now, I'm excited to share, it's publicly available on our website. We'll be able to share that link in the chat, and then it'll also be sent out at the end of the event. So this report demonstrates where we're finding challenges today in access and coverage for sickle cell therapies, and how this can be improved. Just to note, there are companies listed at the bottom. These were the sponsors for this project, so a huge thank you to all of them. But we did want to note that though they supported the project, they were not involved in the design or the research phases. So now we can go ahead and head to the next slide, and I'll get into the methodology. So starting this project was the environmental scan, and this was really to examine drug access criteria. So Avalier and Sickcells identified 4 pharmacy benefit drugs and 1 medical benefit drug. You'll see the table down there that outlines which therapies we studied, their product name, whether medical or pharmacy benefit, the FDA approval date, and whether it's brand or generic. So we were looking at the preferred drug lists and prior authorization criteria summaries, as well as other coverage policies. And this is all as of June 2022. So we hope to be able to continue refreshing this research every year. But for the report, it only includes data that would be relevant as of June 2022. So as you can see, this is the focus of our project, and we can go ahead and head to the next slide. And I did want to note from the table, you can see that we did not consider generic hydroxyurea in the study, but it's our assumption that there is better access and coverage for that. So we decided to focus on the drugs that had the most barriers, so the data would reflect all of the barriers that we were finding. So looking at the data definitions, this is not a comprehensive list. We have a much bigger list of what we were focusing on in the study, and you can read that in the report. But I wanted to call out the biggest focuses that we had. So we were focusing on 5 themes and 5 designations in the PDL or in the state formularies. So these would be starting from the bottom, which would be the most open access was unrestricted. So this means open access. This would state that the plan did not require prior authorization or step therapy. And then moving up from that, we have prior authorization, meaning the payer requires the beneficiary or the physician to get approval. Next would be step therapy, meaning that in order to get access to drug A, someone would have to meet criteria and fail that criteria, either a drug or another criteria. Moving further toward the more restricted side of things would be step therapy and prior authorization as a requirement to get access to a drug. And then, of course, the least open access would be that the drug is not listed. So for the advocacy perspective, we're really hoping to be able to move all of these drugs all the way over to the right on the spectrum or toward the bottom of the list, which would mean unrestricted or open access. Okay, we can go ahead and move to the next slide. So to gain additional insights on the coverage and access landscape, we took the environmental scan to the next step, and this was the survey that I mentioned. So this was split into 2 surveys. One was sent to current state Medicaid directors. Sickcells conducted this outreach. And then another survey was led by Avalier, and this was sent to a broader group of relevant individuals, and this would include folks with current or prior state Medicaid experience. So the survey questions focused on a few different areas, largely coverage and care management, prescription drug management and access, health equity initiatives, and stakeholder engagement. And just to note that in our final report, we have the complete survey that was sent out. So if you're interested in looking at exactly what we asked, how we worded it, that would be in the appendices in our final report. So the Sickcells survey ended up having about 15 respondents. The Avalier survey that was sent out had 25 respondents for a total of 40. And we also include in our final project really detailed methodology on it, exactly how these surveys were administered, including follow-up and things like that. Next slide. Diving in a little bit to the survey results, like I said, we had 40 respondents, and this included results from across all of the 50 states. So if I can draw your attention to the list of states on the right-hand side, so that is the list of the 15 respondents that the Sick Cells survey yielded. These are state-specific responses, and as you can see, we had 40 respondents. We covered all 50 states, meaning that some respondents answered for multiple states. So that's just an important distinction to keep in mind when you're reading the report. And again, all of that is covered in our methodology. But this is because some respondents have purview or experience with their organization in multiple states, so they were able to answer for more than one state. We can go ahead and advance. Getting into the key findings of the report, we highlighted 5 main themes across the environmental scan and the survey. And these really emerged once we sat down and looked at the information that we collected. So moving through them, we have the prevalence of utilization management, stakeholder and contractor engagement, factors influencing decision-making in coverage and access, the role of managed care organizations, and then lastly, health equity initiatives. So I'll go through these one by one and sort of hit them all at a high level, but really encourage you to read the report to get the most detailed information. So go ahead and advance to the next slide. I'll give you a minute here to really look at this graph that we have, but this is getting into the prevalence of utilization management. So utilization management is a way for payers to reduce cost, which is an understandable approach to this. But as we know, utilization management, this includes things like prior authorization and step therapy, which I described before, that also imposes barriers both on the patient population and on the provider population. So it's clear that state Medicaid programs and Medicaid managed care organizations use utilization management techniques to control drug cost and manage appropriate beneficiary access to therapies. Rising to the top of this, like I said, is prior authorization and step therapy. So if you look at the results here, I'll mention that results are enrollment weighted, with weighting based on the total number of Medicaid beneficiaries in each state. So not the number of sickle cell patients using Medicaid, but the total number of beneficiaries in each state. This is really important in terms of understanding the results. But overall, we learned that Medicaid payers require prior authorization and step therapy at least 50% of the time for the therapies that we studied. So that would be Adakveo, Endari, Oxbryta, Cyclos, and Droxia. Droxia, oh, I think someone's unmuted. There we go, thanks. Droxia has the least utilization management of the 5 therapies that we studied, but it also has restricted access 46% of the time in state fee-for-service Medicaid and 22% of the time in managed care Medicaid. So that's just kind of a pullout of what we're seeing under Droxia. But if you look at the graph, it's separated by drug. Adakveo has a composite score that is explained in the report. So you're welcome to read that to understand what we mean by that. But then it breaks it up into those 5 designations that I mentioned before of the formulary. So not listed, or it requires prior authorization and step therapy, or just step therapy, just prior authorization, or it's unrestricted access. So that bright red color that you'll see at the bottom of each of the bar graphs means that's open access. And then as you move to the top, going toward the lighter blue, that's restricted access. So as you can see, just like how Droxia management varies across fee-for-service and managed care organizations, while managed care organizations use more open access, there are other drugs like Cyclos that has more open access in fee-for-service rather than managed care. So it's really important when you're reading through these results to look at each drug individually and understand it from both the perspective of fee-for-service and managed care. As you can see from the graph, Oxbryta and Endari have lower rates of open access and conversely have more open access in fee-for-service Medicaid rather than managed care. I'll give you just another second to sort of engage with that graph, but then we'll go ahead and move into the next slide. So continuing with utilization management, this graph looks at reauthorization. So how often does someone have to request prior authorization? This is from the survey. So the report outlines exactly what this looks like, both in the environmental scan and the survey. But from the survey, we can see that the most common response is that reauthorization is required every 3 months. From the environmental scan, we learned that the most often the most often reauthorization is every 6 to 12 months. But survey respondents still highlighted that it's still pretty common to have reauthorization every 3 months, every 6 months. This becomes a really big issue when you're thinking about patients accessing drugs and having to wait to get a drug that they had been approved for previously, but just have to go through the process again. Obviously, from the provider perspective, that highlights issues with timing and the amount of time that they have to spend putting through these authorizations. So like I mentioned before, from the advocacy perspective, we're looking to head more toward the open access. And some of our recommendations for reauthorization are focusing on reducing the number of times a year as much as possible that someone has to apply for reauthorization. Okay, we can go ahead and go to the next slide. This is getting more into stakeholder and contractor engagement. So the survey respondents indicate that many decision makers consider pharmacy benefit managers, PBMs, input in utilization management. So this was especially true for fee-for-service or state Medicaid programs. So PBMs, some of which interact with states and MCOs, play a huge role in determining access. However, when you're looking at managed care organizations, they tend to look more frequently to, sorry, I got that mixed up. The managed care organizations tend to look more frequently to inputs from pharmacy benefit managers, whereas states and fee-for-service rely on providers and clinical support vendors. So this is really helpful information for us because that means when we're doing outreach to Medicaid, when anyone is doing outreach to Medicaid, including from the patient population and from the sickle cell community, they know exactly what voice to be speaking in and who to be reaching out to make sure that their perspective is heard. It's also really important to note that from the survey, we learned that when decision makers are considering PDL placement and controls, the patients and patient groups are the least consulted stakeholders. So often they're relying on clinical perspectives and comparative clinical information. This is huge because this is the answer to the question of who is making the decisions that we're reading about and how do we best approach them and what information do we bring to them. Next slide. All right, so another thing to note is that most survey respondents reported using evidence of comparative clinical effectiveness and established clinical benefits, like I mentioned before, and this really impacts the decisions they're making about step therapy and prior authorization. Another factor in decision-making is drug net prices. This is a huge factor in setting step therapy criteria. This becomes complicated because net pricing is really complex and often this information is not available to the public. And so it's really hard for folks in the community, providers who are providing comments at coverage decision meetings. It's really difficult for them to find this information and include it and address questions that might arise from the committee about net pricing. Like I mentioned before, we also found that preferences of patients and statements from patient advocacy groups are considered much less frequency than the other factors like pricing and clinical effectiveness. So we can go ahead and advance to the next slide. Moving into the role of managed care organizations. So many Medicaid beneficiaries nationwide have their care managed by an MCO. This became really clear from the survey that we did. And this really speaks to the power and influence that MCOs have on the Medicaid population. So from the survey, we learned that 35 of the 40 respondents reported some or all Medicaid beneficiaries with sickle cell in their states are under the purview of managed care. So this means that finding out more about how managed care make decisions, what they're considering when they're making decisions, this is really crucial to being able to provide important information from the patient perspective and from the community perspective. Moving on to the next slide. Diving in a little deeper into the role of managed care organizations. So we learned that MCOs use prior authorization more often than fee-for-service programs, but they generally apply less step therapy. So I pulled out the example of Oxbryta here on the right. Again, it's the 5 designations from the PDL, red being most open access, light blue being least open access. We also learned that based on the information they have available, MCOs list their criteria more often, but this criteria is often split across many different documents, and it's pretty hard to pinpoint them. It's hard to find all the documents and understand exactly what is required to gain access to a specific drug. Another really important thing to mention is that some states with MCOs manage drugs through full drug carve-outs or uniform preferred drug lists, reducing the influence of their MCO. So this is a really important finding. I unfortunately don't have much time to get into it today, but we talk about that a lot in the report. And so if that is an area of interest, I really encourage you to seek that area of the report out. So moving on. The second to last initiative here is looking at health equity. So from the survey, it is clear that state Medicaid programs are taking steps to address health equity and social determinants of health. But what we found is that they're increasingly using their MCO contracts to screen for social determinants of health and are focusing really on data collection and data reporting to address health equity. This shows initiative, but it also leaves room for opportunities. So it shows that specific policies and programs designed to improve equity for individuals with sickle cell are still needed. We're still listed, or we're still really restricted in the realm of data collection, which is a great first step. But that means that the next step is taking that data and creating actionable programs. So at the bottom here, I pulled out a few states' survey responses in terms of what they are doing to address health equity and social determinants of health. There is a more complete list in the report. So I encourage you, if you're interested in what other states are doing, you can look at these options and see what your state could do or how you could build on these. We can go ahead and advance. So this is getting close to the end. The full conclusions and recommendations separated by theme are in the report. I didn't really want to get too much into it in this presentation because we wanted to use this presentation more as a way to set the stage for the rest of the day, the day's conversations, and in the various sessions. The report has really complete information, like I said, about the methodology behind the environmental scan, the survey, a lot more graphs than I was able to get into in this presentation, and some of them are more complex, and so it's just better to kind of sit with them. But I really hope, and we really hope, that you make it over to our website to get access to the report and read it, provide us with your thoughts, reach out to us with questions. We're really happy to engage with you on this. The last thing I wanted to mention was sort of another initiative that we did a little earlier in the year, so we can advance to the next slide. This was a white paper we created prior to the Medicaid project, and this was looking at advancing stakeholder engagement with Medicaid and really centering the patient voice. So this is a white paper we produced. The background was really looking at coverage for sickle cell treatments, and a lot of it was what eventually inspired us to do the Medicaid project. And this is sort of a recap of what Sick Cells has done specifically in this space and working with advocates who are in our ambassador program or other advocates across the country. So to date, we've trained over 25 individuals to advocate for sickle cell disease in coverage decision meetings across the United States. You can go ahead and advance to the next slide. A little bit more about this paper. It's looking at a few different things. So existing barriers to engagement. Again, this is from the patient perspective. So what we're seeing while we're engaging with Medicaid. Some of these big themes that we found and experienced over the past few years in this work is the lack of specific expertise in the coverage decision committees, restrictive public engagement procedures like deadlines for signing up, what you can talk about in your comments, how much room you have. Additionally, limited transparency in this decision making. A lot of the decisions are made in sort of closed executive sessions that don't have a readout. So it's really hard to know after folks provide input what stuck with the committee, what was helpful, what was useful information to them. And then the last existing barrier that we saw really was an insufficient use of existing expert groups like sickle cell task forces and rare disease advisory council. This white paper also outlines a few different case studies. I won't get into them now, but there's sort of a brief description of what the case study focuses on. Some of them are really great experiences with boards. Some of them are highlighting a lack of engagement with local groups. Some of them are pulling out sort of the power of patient advocacy and a really educated board and what that can mean for decisions that are made. We also have recommendations in this white paper for the sickle cell community, as well as for state Medicaid programs and managed care organizations. And then just a quick note, the last thing is up in the top right, you'll see that we also had a blog that was written by 2 of our ambassadors after they engaged with Medicaid, sort of recapping their experience and what they walked away from the experience with. So I know that this was sort of a fast and furious recap of our Medicaid project and of this white paper, but thank you so much for your time. I think we're about ready to get into questions. Happy to take some for the next 5 minutes. But again, feel free to reach out to us. We're happy to speak more with you one-on-one, and we hope you enjoy the report. All right, so I think as we did before, feel free to put questions into the comment section. I'll try and read through them as much as I can. It looks like we have quite a few coming in. Thank you, Maggie, for putting the link to the report in there and for answering some of the questions. I see one here. Let me pull that up. So John asked, since hydroxyurea is generic, when you have droxia, are you referring to all hydroxyurea or just the brand? So when we say droxia in the report, it is just the brand. We looked at droxia and cyclose, which are both hydroxyurea. Let's see. Another person commented that prior authorization burden looks very large compared to other disease areas. We would love to learn more if you have insight into other disease areas, what you're seeing and what information you have, because I think that can really strengthen what we're seeing and can further the conversation about the goal that we can move toward in terms of what works both for payers and for providers and for the patient population. So thank you for that point. Looks like we have 3 more minutes. Feel free to pop anything into the chat. Thank you, Maggie. It looks like she also put the link to the white paper in there, so you can access that directly if you want to pull it up and have it waiting for you later. We have another question here. The DURB acronym, DURB, what does this acronym stand for? So it's the Drug Utilization Review Board. When we were looking at coverage committees, they sort of pop up under a lot of different names, and they have slightly different iterations of exactly what they focus on. So the DUR board is one iteration of that. There is also pharmacy and therapeutics, P&T. We also see drug and therapeutics, D&T. We see prior authorization committees. So there are lots of different iteration of different committees and exactly what they focus on. And that's actually a really important point, because depending on what the committee is, we sort of tailor what we're focusing on, depending on what control and what they're able to recommend. So I think we'll go ahead, unless anyone has any more specific questions. Thanks, Maggie, for putting that in there. We can go ahead and take a quick break. We'll give you back a couple minutes here. So let's go ahead and wrap it up. Thanks so much. We'll see you back in a few minutes.
Hello, and welcome to our next session entitled Improving Equity and Affordability of Sickle Cell Disease Therapies, Best Practices in Benefit Strategies and Payer Management. My name is Terry Richardson. I am the Vice President of Education, Strategy, and Development at Impact Education, LLC. We are pleased to be able to provide you today with what we hope will be an informative and meaningful continuing education activity. Before we get started, I would like to remind you to use the comment tab to submit any questions throughout the session. We will do our best to get to everyone's questions at the end of the session. Today's session is jointly provided by SickCells, Medical Education Resources, and Impact Education LLC, and is designated for 1.0 contact hours of continuing education credit. Please refer to the CE/CME handout available to download under additional resources. At the conclusion of today's program, you will be prompted to complete an evaluation, which you must submit in order to receive credit. Once you complete your evaluation, you may download your certificate, or for pharmacists, you can receive instructions to submit credit to CPE Monitor. Now we'd like to start with 2 polling questions. You can go to the next slide. If you don't see the ability to respond to the poll, you can go ahead and put your response in the comment section. Our first poll. Based on recommendations from the National Heart and Lung Blood Institute, treatment with hydroxyurea contains a strong recommendation of high-quality evidence for which of the following patient types? You can go on to the next poll question. The second question, right now, how confident are you in your ability to implement and/or recommend patient-centered care and services that support appropriate treatment, coverage, and access for patients with sickle cell disease? On a scale of 1 to 6, where 1 is not confident and 6 is very confident. Thank you. You can go to the next slide. For today's program, I will be joined by Francesca Valentine, Dr. Shivi Jain, Dr. Emily Teseo, and Dr. Terry Cothran. Next slide. Today's learning objectives are shown here. And at this time, I would like to hand it over to Francesca Valentine, mother of winged sickle cell disease warrior Marcus. And to remind you to watch the pre-session video Francesca recorded detailing Marcus's journey with sickle cell disease. The link to the video is available in the CE handout and will also be sent via email following the session. Welcome, Francesca.
Thank you very much. Thank you, everyone, for attending. We took one incident from many that Marcus experienced to highlight not just the financial cost, but the unseen burdens of the disease process on the patient, the family, etc. Next slide, please. Marcus was very positive despite his myriad of complications. And if you watch the recorded video, you'll get to see more of them in detail. So we're going to focus in on his wounds because that gives you a look at the freight train that comes through when things are not mitigated, as we're talking about disease modifying drugs, etc. Next slide, please. Marcus, by the time he was a young adult, 2014, he developed wounds, and they were recurring. This episode that we're referring to here was one of many, but it was despite being on hydroxyurea for nearly 20 years, also having stellar medical and surgical care, absolutely stellar. He had private insurance. He also had Medicaid at some point that we were denied, and then etc. So it wasn't very helpful. The cost of one episode of sepsis was well over $200,000. That's the actual inpatient hospital bill. that does not include consultants, radiology, special procedures, any such thing. As a result of that, his sickle cell had repeated crisis to the point where his AVN resulted in femoral head collapse. Next slide, please. The femoral head collapse rendered him bedridden, and he could not have a hip replacement until the wounds were closed. To close the wounds required 18 months of volume exchanges, and those were several thousand each visit. In the video, when you watch the crisis video, that was his first wound debridement. He came out of the OR in a full sickle crisis. Subsequently, back to the OR for further debridement was not an option. So we turned to topical treatments, and also having to get approval for the topical treatments, often because there was a lack of understanding of the physiology of sickle cell disease in the reviewing boards. Marcus also had access to other treatments that maybe were not fully publicly available, like topical hyperbaric oxygen. Part of it is because I'm a critical care nurse by profession, and I had access with PV surgeons, podiatry, and he had a well-organized and put together healthcare team. That is not common. So the cycle of disease, unmitigated, one event can create devastating consequences for the patient in his dignity, his humanity, lose the inability to walk, unforeseen expenses that aren't documented anywhere in the full scope. I think we spent $2,000 on various types of shoes. Clearly, we're in a Midwest climate, and you cannot walk outside with garbage bags and slippers over your bandages. Fortunately, at some point, we do have Blue Cross Blue Shield. They paid for prescription shoes at that point. That was part of the process of restoring his dignity. Overall, this one episode easily topped over $500,000. Because of the wounds, he had the back-to-back sepsis, which led to him losing his portacath. He needed a PICC line. Then he needed the portacath replaced. Then he had the 18 months of exchange transfusions. Next slide, please. So that we could restore his ability to walk, and also he gained a few inches. He was almost as tall as his dad, but he regained his life. He could go outside without assistance. In the meanwhile, the home environment was pretty much turned into a hospital. Our dining room furniture we replaced with a hospital bed, urinals, because he was essentially bedridden. And this all triggered from the wounds to the point where in my video, I explained that we discussed what he wanted in terms of possible amputation. We also had access to high quality bandages and some of the newer products on the market. We had the compounded wound creams, all of this prior to the other disease modifiers. So while being on hydroxyurea, all this occurred. Also, once the disease modifiers came to market, we were able to get approval, but that it wasn't, even with our situation, that wasn't the easiest process. We still had to prove that he was a candidate for the disease modifiers. And if you look at my pre-recordings and look at his list of complications, if we don't start the disease modifiers now that they're here, then the youth won't be available to even be here for a cure. We even had to do cost benefit analysis and submit to our insurance company to show them that some of the ways we proceeded would benefit as cost effective, plus keep him in the home, which is far less costly than in the hospital. But that cycle of unmitigated symptomology is, Dr. Zaidi used the word dismantle. It dismantles the person with sickle cell a little bit at a time, every single body system, until the freight train comes through and they're not here anymore. So the disease modifiers are very important. And as professionals and with our understanding of physiology, step therapy, because we are licensed and understand physiology, there should not even be a discussion, in my opinion, as a nurse, professional nurse, and a mother. Each drug functions on a different part of the disease process. And we know we wouldn't ask a diabetic with CKD to take metformin. We know that if someone has prostate cancer, we're not going to question them when they tell us their hip hurts and they're having trouble walking. We're going to scan them and look for metastasis. With sickle cell, your hip hurts. We should not be hearing drug seeking. We should be hearing clinical response to a symptom of the disease, a complication of the disease that creates other chronic diseases. And we should try to mitigate these as fast as possible so that the person has a fighting chance to live longer and live a life of quality with dignity and respect. Next slide. This was after Marcus's hip replacement. He was able to return to the therapeutic riding stable. He was as tall as his father. And it was his dream that everyone see and understand what sickle cell really does. So he therefore agreed to have himself filmed in some of the most vulnerable situations so that what we learn in our slides, we can actually apply in daily life. And another point Dr. Zaidi made, nursing doesn't have sickle cell education either. For my capstone project, I went through 16 textbooks to find one with a chapter on hemoglobinopathies. So it's not widely taught. Next slide, please. Hopefully, Marcus will see us and know that we are pushing forward to mitigate the symptoms before they become tragedies and pave the way for organ preservation so that when the cure comes, the persons are here to receive the cure. Thank you for your time.
Thank you, Francesca. It is so important to found our conversations and our policies that we think about in the patient and the patient experience. So we do appreciate your willingness to share Marcus's story with us today.
Thank you.
At this time, I would like to introduce Dr. Shivi Jain, who will present an overview of sickle cell disease treatments and the importance of patient-centered care. Dr. Jain is the director of the Diagnostic Bone Marrow Biopsy Lab and assistant professor in the Department of Internal Medicine, a division of the Hematology, Oncology, and Cell Therapy at Rush Medical College. Welcome, Dr. Jain.
Thank you to Sickcells and the team here for this opportunity. Francesca, I would just want to thank you for sharing that moving story and showing a lot of us as providers what the real story is, or a journey of a sickle cell patient is in our current times. And I will today be addressing the treatments for sickle cell disease and the importance of patient-centered care. Next slide, please. So before we start further, I just want to share about the history of sickle cell disease. In 1910, Walter Clement Noel, who was A dental student visiting Chicago from Grenada used to get admitted in the months of December during the cold winters with anemia and generalized body pain. And that is when first time Dr. Herrick, who was then a practicing cardiologist at Presbyterian Hospital, and his intern, Dr. Irons, made the first description of sickle cell disease in 1910. And that is when we first learned about the sickle cell disease. The St. Luke's Presbyterian Hospital is now known as the Rush University Medical Center in Chicago. Next slide, please. So we all are familiar that sickle cell disease is a genetic disorder. It is a monogenic disorder, means a single point mutation in the beta globin gene that causes replacement of the glutamic acid, which is an amino acid, to valine, leads to the change from a normal hemoglobin with normal red cells to the sickle hemoglobin. That is, the hemoglobin becomes polymerized and causes damage to the red cells and transforms their shape into these sickled shaped cells in patients with sickle cell disease. Next slide. Next, please. So that's just highlighting the mutation in the beta globin gene. Next slide. Next. So this slide shows the worldwide distribution of sickle cell disease. Currently, the patients with sickle cell disease live across, the world. They reside in all countries. As highlighted here, sickle cell disease first originated in Africa, and you can still see a higher prevalence of that disease in certain African countries like Nigeria and Congo. Next. Also, patients with sickle cell disease are in higher proportions in Middle East. Next. And Southeast Asia, as you can see highlighted here, where sickle cell disease is more commonly found associated with thalassemia. Next. We have made immense progress in terms of closing the gap in life expectancy for our patients with sickle cell disease, especially in the pediatric world. Now that we have universal screening, penicillin prophylaxis, more widespread use of hydroxyurea and awareness about the benefits of hydroxyurea, and using strategies like primary transfusions to reduce the risk of stroke in children with sickle cell disease. But when it comes to the adults, I think we are still learning about the disease. There is still about a 30-year age gap between life expectancy for adults with sickle cell disease when you compare it to the general population. So there is a lot of room for improvement for the adult programs who care for adult patients with sickle cell disease. Next slide, please. This slide just highlights, I'm sorry, it's a busy slide, but it highlights that sickle cell disease is not just a hemolytic anemia or a blood disorder like it is taught mostly in medical schools. Sickle cell disease is a multi-system disease. Every organ that blood flows through can develop acute and chronic complications from sickle cell disease. I'm not going to read every single one of them, but every organ, starting from the eye to the toe, retinopathy, heart problems, pulmonary hypertension, everything can happen due to sickle cell disease. So patients with sickle cell disease live with a very significant burden due to their disorder, and it's almost comparable to patients with cancer like leukemia or colorectal cancer. And the burden is even higher than breast cancer and Alzheimer's disease, some of the diseases that have over the years gained more attention and funding support when we compare it to sickle cell disease. Next slide, please. Next. So this slide, we will go in several sections, but really highlights the pathophysiology of sickle cell disease. Next. Next. So as you can see here, the area focused on the slide is nitric oxide, which is a very important enzyme for the health of the blood vessel, the endothelium. And when there is hemolysis, then it interferes with the oxidation process for the cells, and it causes depletion of the nitric oxide, which can then lead to constriction of the blood vessels. Next. It can also lead to release of free heme in the blood, which can further add to the oxidative damage. Next. This causes release of certain mediators that can upregulate inflammation and further add to the endothelial damage. Next. It also causes decreased ATP in the platelets, so the platelets can become activated. Next. And all those interactions can eventually lead to the cells to stick to each other, as you can see in the upper corner, and lead to what we call vasoocclusion, which then decreases the blood supply to the critical organs and leads to development of pain and other complications in sickle cell disease. So once again, the point here is it's not just hemolytic anemia, it's actually a chronic inflammatory vascular disorder. Next slide, please. So now we are going to review the sickle cell disease treatments, and we'll start by talking about the standard of care, which has already been discussed in this meeting so far, which is hydroxyurea. Next slide. So hydroxyurea, due to several benefits, still is the standard of care and should be the first choice when you are considering disease-modifying treatment for sickle cell disease due to several reasons as shown here. It helps in improvement of the blood cell production from the bone marrow. It reduces inflammation. It increases the production of nitric oxide. It also improves the flow of the red cells by making them a little bit larger so that they can withstand hypoxia better. And most of all, it increases the production of the hemoglobin F, or the fetal hemoglobin, so that the cells can hold on to oxygen a little bit longer and not break down or hemolyze easily. Next slide. This study is what I really like to discuss with my patients because there is still a lot of stigma around use of hydroxyurea. This is the MSH study that followed patients for 17 and a half years who took hydroxyurea. Next. Please go back to that slide. I apologize. So the study clearly shows here that patients who took hydroxyurea and stayed on it for more than 15 years, really not only did they had a better survival as compared to patients who took hydroxyurea for less than 5 years. So there is clearly an impact on mortality for patients with sickle cell disease, and also some suggestion of improvement of quality of life. Next slide, please. So according to the NHLBI expert panel report, which was released in 2014, these are the indications for patients with hydroxyurea, and actually also addresses one of our pre-test questions. So all individuals who have 3 or more pain crises a year, who have 1 or more episode of acute chest syndrome, have anemia that affects their quality of life, or infants starting as early as 9 months of age, children and young adults with sickle cell disease should receive hydroxyurea irrespective of what the complications they have had. Next slide. So these will be the arrows. Please keep going. Next. Thank you. So when we have this good therapy, hydroxyurea, and we know that there are long-term benefits of hydroxyurea, why do we still need newer therapies for sickle cell disease? That is because, just like Fran has elicited in Marcus's case, it's still not enough. A lot of studies have shown that patients who take hydroxyurea still need some more additional benefit. As in one of this study, you can see that there was younger age of death and higher risk of death in patients, and 41% of this patient population was already on hydroxyurea, and 39% of them were also receiving blood transfusions on a very regular basis. So this does tell us, now that we have a better understanding of the pathophysiology, that we still need to go a few steps ahead and do more for our patients with sickle cell disease. Next slide. So this slide just tells you various targets that are being studied to develop newer disease-modifying agents for sickle cell disease. Next slide, please. So there are drugs that are working on improving the oxygen affinity for the red cells. Next. There are strategies, again, to affect and reduce the polymerization for hemoglobin S, and we know voxelotor is one of those medications that was approved in 2019. Next. And then there are strategies to target some of the other systemic targets. Next. And then also to target some of the adhesion proteins in the blood vessels that get upregulated because of increased inflammation. And crizanlizumab was one of the medications approved in 2019 that is a p-selectin inhibitor. Next. So L-glutamine is one of the earlier medications. It was really a big breakthrough that after 20 years of hydroxyurea being approved, it was finally received its FDA approval in 2017. It is an antioxidant, and it helps by reducing pain crisis in sickle cell disease. Next. As you can see here in the clinical trial, which was a phase 3 randomized controlled trial using L-glutamine in patients greater than 5 years of age, you could see that with use, there was about a 25% reduction in the pain crisis in the group that received L-glutamine over a 48-week course. Next. You can also see that the time to development of the first and the second pain crisis was delayed in the cohort in the group that received L-glutamine, and these results were statistically significant. Next. So L-glutamine attained approval in 2017. There were some benefits, and again, an option to offer patients who were not able to tolerate hydroxyurea or the disease was still not under control if they were already on hydroxyurea. Then in 2019, crizanlizumab, which is a p-selectin inhibitor, got approval. It reduces the adhesion or the sticking of the red cells and the platelets and the white cells to the endothelium and to each other. It's a monoclonal antibody given as an IV infusion once every 4 weeks. Next slide, please. So this tells us about the benefits of crizanlizumab, and in the study, the SUSTAIN trial, which was the pivotal study, it was demonstrated that the patients who got crizanlizumab at the dose of 5 milligram per kilogram achieved about 45.3% reduction in their annual pain crisis. This was statistically significant. Next slide, please. And also with use of crizanlizumab, there was a delay in the onset of pain crisis. 2 different dosings were studied in the clinical trial. 5 milligram per kilogram dosing is the dose that showed more benefit, and the benefit of reduction in the pain crisis was seen as early as 2 weeks after the start of treatment. Next slide, please. So another drug, voxelotor, also got approval in 2019. This is an oral drug that helps with decreasing the hemoglobin S polymerization and reducing anemia and hemolysis. Next slide, please. It is the first-in-class orally administered drug to increase the affinity of oxygen for hemoglobin, sickle hemoglobin. Next. It was studied in a phase 3 randomized placebo-controlled trial, which was a pivotal study called the HOPE trial. Next. Again, 2 different dosings for voxelotor were studied in the clinical trial, and the 1500 milligram dose daily was the one that was shown to have benefit. Next. So this just shows you the composition of the patient population that participated and was studied in the clinical trial. What I want to focus here is all sickle cell genotypes were studied in the trial. Next slide, please. So initially was studied in patients age greater than 12, but now it's also approved for kids greater than 5. Next slide, please. Next, please. I already talked about the genotypes. Next. Voxelotor helps improve hemoglobin level by at least 1 point, and the effect can be seen as early as 2 weeks. 59% patients in the study were able to achieve this goal, and it was statistically significant. Next. Keep going. Again, you can see the benefit here as early as 2 weeks, as indicated by the arrow. Next. And these are some of the other agents which are in pipeline and being developed as disease-modifying therapy for sickle cell patients. Next. I cannot finish the talk by talking about gene therapy. There are different approaches that we are using right now for gene therapy. Just last week, gene therapy was approved for thalassemia patients. So I'm really hopeful that this will come through even for our sickle cell patients. You can add the gene, add a normal hemoglobin gene. You can edit. Next. You can do gene editing. Next. You can silence a gene. So if you silence the BCL11A gene, then you can continue to have a higher level of hemoglobin F in the red cells for patients with sickle cell disease. Next. And since sickle cell disease is a monogenic disorder, you can even go in and correct that mutation in the beta globin gene and lead to development of normal hemoglobin. So these are the different approaches that are being used for gene therapy for sickle cell patients. Next. And next. So these 2 studies that are highlighted here are using a viral vector to carry the modified gene and being studied in sickle cell disease. Next. These are the studies that are using certain enzymes to edit the gene and thus improve the hemoglobin F levels and reduce hemolysis in patients with sickle cell disease. Next. Next. So that is all. That brings me to the end of my talk, and thank you everybody for your time.
Thank you, Dr. Jane. That was a great overview and to help us with the foundation of the treatment options as we're moving forward to think about the importance of developing patient-centered care. At this time, I would like to introduce Dr. Emily Seo. Dr. Seo is a clinical pharmacist at Premera, and Dr. Terry Cothran. He is the Senior Pharmacy Director at the Oklahoma Healthcare Authority. They will share payer perspectives on sickle cell disease, treatment outcomes, and coverage policies. Welcome to both of you.
Thank you, Terry. Can you hear me okay?
We can hear you. Thank you.
Perfect. Thank you. And I just wanted to apologize for not being on camera, but on the next slide, I just wanted to share some lessons learned from our experience supporting sickle cell disease members, specifically by exempting members with sickle cell disease from our opioid criteria. We really found that taking advantage of any operational efficiencies available in the electronic prior authorization and utilization management process, really clearly communicating at every opportunity in the medical policy, in provider and member PA response letters, in the electronic prior authorization questions, that members with sickle cell disease are exempt from the opioid criteria, and providing education to internal teams about the updates so that they can share this information with providers as well as members when needed really helps to decrease the administrative burden for providers and the members as well associated with filling opioids for members with sickle cell disease. And lastly, like with every implementation, we found that having a clear champion, having a leader to support the operational updates, and someone to serve the role of a project manager can help align goals and support a successful implementation. On the next slide, I just wanted to share that Premera has a history of promoting safe and thoughtful use of opioids. We have a prior authorization requirement for members who are requesting a greater than 7-day supply of an opioid when they have not been treated with an opioid recently, and a prior authorization for all long-acting opioids as well. We also have a quantity limit check for opioids, and we have around 142 commercial pharmacy benefit members with sickle cell disease last year, and roughly 43% or 61 of those members used an opioid in that previous year in 2021, while about 8% of these sickle cell disease members had used a long-acting opioid in 2021. On the next slide, in April of 2019, the CDC clarified that their guideline for prescribing opioids for chronic pain was not intended to deny clinically appropriate opioid therapy to any patients who suffer from acute or chronic pain from having sickle cell disease. And following that, in June of 2019, CMS recommended that beneficiaries with sickle cell disease be excluded from real-time opioid safety edits. Following that, in January of 2020, the Institute for Clinical and Economic Review, or ICER, published their draft sickle cell disease report, which really provided valuable insights into the patient perspective. As a result of all this guidance from the CDC, CMS, and ICER, Premera excluded sickle cell disease members from being subject to our opioid utilization management requirements in April of 2020. On the next slide, after the CDC's clarification, Premera's pharmacy team met with and received approval from our key medical directors to exempt members with sickle cell disease from our opioid utilization management policy. This exemption was brought to and approved by the P&T committee, and then was brought to and approved by our medical policy committee. And when it came to the implementation, our goal was to make it as easy as possible for providers and patients to know that members with sickle cell disease are exempt from our opioid utilization management criteria. We updated our public medical policy to clearly note that members with sickle cell disease do not need to meet the requirements in the policy. We added a question in the question set that is presented to providers when they request an electronic prior authorization for an opioid that asks whether a member has sickle cell disease to help identify these members. Within our opioid utilization management letters sent to providers and members, we note that patients with sickle cell disease do not need to meet these requirements. And to help streamline the process for receiving an opioid, we allowed member IDs associated with a sickle cell disease diagnosis code and member IDs with a claim for a sickle cell disease drug to bypass the stop at the pharmacy when the patient goes to pick up their opioid. And lastly, this is not noted on the slide, but I also wanted to mention that we really found it helpful to provide education about the exemption of members with sickle cell disease from this criteria to the case management teams, as most members with sickle cell disease tend to be in close contact with the case manager. And we also found it helpful to note this exemption in any relevant customer service job aids or tools so that this information is available to them if a provider or a member calls in with a question. On the next slide, we monitored the utilization of opioids by our members with sickle cell disease after the implementation of the exemption and found really modest changes in the number of sickle cell disease members using an opioid after the exemption went into effect in April 2020. About 41% of our sickle cell disease members used an opioid in 2019 versus 43% in 2021. We also saw modest changes in the percentage of sickle cell disease members using a long-acting opioid after the exemption was put in place. About 7% of our sickle cell disease members using a long-acting opioid in 2019 versus 8% in 2021. On the next slide, looking a little deeper, we saw a modest increase in the percentage of sickle cell disease members who had greater than 90 morphine milligram equivalents, or MME, per day year over year, with a 14% increase compared in 2021 to 2020. When we looked at members with sickle cell disease who were using opioids chronically, and specifically looking at those members who were using an opioid chronically and were also using what we'll call a high-risk drug, such as a muscle relaxant at the same time, we saw a modest increase in the number of members with sickle cell disease who were using an opioid chronically and using a high-risk drug at the same time, with about 29.1% of members with sickle cell disease using an opioid chronically with a high-risk drug at the same time in 2019 versus 29.4% in 2021. On the next slide, at Premera, to really help us get to know our members with sickle cell disease, we found it incredibly helpful to be able to have detailed member-specific information readily available in a dashboard format. And this dashboard we have in place is for members with rare diseases, and it includes members with sickle cell disease. It aggregates and displays the information we have available for our members, and we use it to support our understanding of what our members with sickle cell disease experience to inform our formulary and utilization management discussions. On this dashboard, there's an individual member view and a disease summary view with trends and updates. You can review summarized or detailed information about the other diseases the member has, the costs associated with their care, more information about the member themselves, such as their age, gender, which line of business or employer group they're associated with, where they live, the type and frequency of their healthcare visits, services, and treatments they receive. And a tool like this is not only useful for informing formulary and utilization management decisions, but it's also great for monitoring treatment outcomes and adherence and providing that information quickly to teams that would find that information valuable. On the next slide, when it comes to addressing disparities, specifically in formulary development, we have acknowledged within Premera that there really is a need for the pharmacy team to lead the charge in bringing these considerations to the forefront. In meetings like our independent P&T committee, internal medical policy committee, and other forums, though health disparities in sickle cell disease and other disease areas are important to these decision makers, there can also just be so many other demands on their time and attention. And we have found that some targeted questions such as the following may be helpful to guide a conversation when appropriate. Questions such as, will the drug be used in an underserved population? Are there population-specific differences in pharmacodynamics, pharmacokinetics, or other areas? What barriers to accessing this treatment could members face? How can we help? What education do providers need to ensure optimal use of the drug? What challenges does the disease pose in a patient's daily life? How may the drug under review help overcome these challenges? And then, what socioeconomic, logistical, geographical, or other factors might hinder successful use of a treatment? And, what cultural factors, such as potential distrust of the healthcare system, might hinder successful utilization of a treatment? On the next slide, are resources that we utilize to address the questions we might ask or receive, such as speaking with a physician expert that treats the disease, utilizing resources provided by or speaking to patient organizations representing the patient population being discussed, using targeted literature searches focused on the patient population of interest, and ICER reports if they are available. On the next slide, looking forward, Premera is evaluating how health disparity considerations are reviewed during our P&T committee meetings. And below, I've copied a portion of our value matrix within our current standard monograph template. We are currently reviewing how this section and other areas of the monograph template can be modified to better highlight relevant health disparity considerations within a review. And we're also looking at opportunities to provide annual health disparity trainings to our P&T committee members, our medical policy committee members, and other clinical team members within our organization based on the recommendations from the AMCP Racial Health Disparities Partnership Forum. Lastly, we are looking into opportunities to partner with some of our key provider systems in our network to provide emergency department sickle cell disease racial bias and treatment disparities training. But, in closing, at Premera, I just want to say that we acknowledge that structural racism exists, that it impacts the provision of healthcare for patients with sickle cell disease, and we seek to integrate proactive strategies to improve equity, really beginning with education and training within our own sphere of influence. Thank you so much for your attention, and with that, I will turn it over to Terry.
All right, I'm glad to be here. Appreciate everyone on the call. Can we go to the next slide, please? I'm just going to touch on a few things to share around the Medicaid space to provide a little insight that might add some clarity, if you will. You'll notice this slide, I think we viewed a little bit earlier, and you'll see some differences probably in different states based on how they're set up. Some have managed care organizations, some still have fee-for-service. Based on those alignments will determine, how some types of criteria or utilization management is put into place and what that looks like. So I just mentioned that to know that there'll be some variation from state to state depending on how the payer is set up. Next slide, please. Changing, treatments in the landscape. Definitely, as we've talked about with the gene therapies, the one that was just approved last week, and then hopefully the upcoming ones. I think everyone's excited about these. Hopefully they'll be as beneficial as we think. They do come with a bit of a price tag, so we have to kind of work that in, and then that's what takes us kind of to some of the next bullets, trying to find ways to pay for those and pay for the value, I guess. We often look at those, at least when they're brought to market, the pricing is often looked at what's the cost of a member for a lifetime versus a cure for a lifetime. And they figure that into their cost analysis. So value-based contracts is something we've done a bit with, and those have shown some benefit. So we're probably going to stay on that track as well, but look for other opportunities to be able to afford to get these to all of the members that need it. So next slide, please. And then just on the health equity piece, there's pieces to that. The social determinants of health is very important. We have some work in that space. I would venture to say most states probably have, if they had more resources, could probably do more work in that space. So there's probably room for improvement there. DUR board on the next bottom part of that sentence there. We do have a DUR board. That's how our products are. Utilization management is put on our products. It consists of physicians and pharmacists and a couple other folks that sit on that board and make those decisions. That board is open to the public, so we do provide opportunity for folks to comment even outside of the board folks themselves. So we like to engage the outside folks and the providers. There's another piece down here when it says outreach to community experts. When we are setting utilization management criteria, we will often reach out to some of the experts in the area, which like hemophilia, for example, we have several providers that when we work in that space, we run things by them for input and analysis. So we find that very helpful. As we move on down the slide, using cost-effective analysis and real-world data, we have a relationship with the College of Pharmacy that helps support our DUR process as well, and they're able to do a lot of data work that helps us look at our patient populations and see where we might have room for improvement. We could look at certain analysis, like when someone started therapy, was there a reduction in opioid use? Maybe that's a factor that shows that they're improving in some manner. So we do have the capability to do that. I'm not sure all states do, but we find that very beneficial. And then again, just the last bullet is kind of a recap of what I had mentioned before. We do engage the stakeholders when we are working in that space to try to make sure that we have a full picture of what we're putting in place. So, and I believe that's the last slide for me.
Great, thank you. It's really helpful to hear from both of you and the different programs and efforts that are being put in place to really better understand some of the unique considerations about providing care and coverage for patients with sickle cell disease. So thank you for sharing that. At this point, I'd like to ask all of our faculty to come back on. We're going to go into a short panel discussion, and you can turn your cameras back on and your audio back on. And Fran, we're gonna focus our discussion here really on the opportunities to improve equity, affordability, and appropriate access to treatment care. So, from your perspective as a mother of a patient with sickle cell disease, as a nurse, what do you see really as the key opportunities to improve access for patients?
So, first, communication in various forms. We can never assume that everyone has computer access. Also, cell phone access could be possibly limited minutes, so they can't spend 45 of those minutes on hold if they only have 100 minutes. Mobility. So it's more of a holistic approach to the population because of the complications. Right up front, we have to do a better job at identifying the complications so that we can manage the chronic diseases that sickle cell causes. If you're educating someone, but you're not aware that they've had a stroke already, or they're not comprehending what you're saying as, say, a navigator or a provider, a clinic nurse, you need to go a step further and investigate why the comprehension level is not where it should be. Is it the way it's presented, or has the person had a complication now that has given them another disability, something else disabling? Maybe they can't get to their local pharmacy because they can't take 3 buses and a train. They might have heart failure now from sickle cell, and they can't walk that far. So we have to utilize what we've learned from other diseases, heart failure, diabetes, emphysema, COPD, all these things, and apply them with sickle cell. Use some of this. We don't have to reinvent the wheel. Use some of that same case management skills we've acquired and use them for sickle cell, because sickle cell causes, like Dr. James said, from your head all the way to your toe and everywhere in between. Maybe start with communication and meet the patient where they're at. How many times have we heard eat a low sodium diet? What does that really mean to a patient? It's going to mean something different. If I can jump in my car and run over to Whole Food, it's going to mean something absolutely different if I have to go to the food pantry.
Good
or
point.
the dollar store for my meal.
Yeah, good points. Thank you for that. And Dr. Jade, what are your thoughts and what are your perspectives on Francesca's comments about communication, and then also what you would like to see as a treating physician that we could do differently for patients with sickle cell disease?
I can't agree with Francesca more. It is so important, and I want to highlight this, that one part of our fraternity is making these strides and developing these new treatments, and we are advancing to gene therapy. But in reality, we are still struggling even for the standard of care to be available to the patients without problems. This should not be now. The disease has been here for more than 100 years, that patients have to justify why they need hydroxyurea. Why can't voxelotor be added to hydroxyurea? What is hydroxyurea failure? None of the clinical trials that studied these medicines included patients who failed hydroxyurea. 2/3 of the patient populations were on a hydroxyurea. So when it comes, we're trying to model the results from the clinical trial in real life scenarios, but we're not giving the patient that access in the real life.
Right.
When it comes to reimbursement, I think that's the biggest challenge. And of course, in addition to that, the understanding, the education about sickle cell, like Fran said, meet the patient where the patient is. Instead of saying, oh, he missed his appointment today, go a step ahead and see why the patient was not able to make it to the appointment. Was it transportation? Did they forget? Don't forget that these patients, they deal with a lot of emotional and, psychological issues with the disease. It might not just be as easy as, your appointment is in 2 weeks. We'll see you then. They may not remember. They may need reminders. Role for community-based organizations, community health workers, they need that. And their need should be no different than some of the other chronic disorder patients. That's what I want to say.
Great.
Could I add something about the pain that I just heard? We also need to identify in these studies which pain was being treated. I'll use Marcus's example. His sickle pain was managed with Dilaudid, and because his kidneys were well managed, he could use an anti-inflammatory. But when he developed femoral head collapse, he required 125 mics of fentanyl just to be able to stand up and use a urinal. Which pain are we working on when we do the study? Is it part of the questions when we're doing the assessment? Are you using the medicine prescribed for the sickle pain, or is there another pain that you're taking medication for?
Yep, very good points, and just the reminder to be very patient-centered in the investigation and understanding why the patient's presenting. That's a great addition. Dr. Cothran, so hearing these perspectives and really understanding the significant role that Medicaid programs play in providing coverage to so many patients with sickle cell disease, what are your thoughts around how we can maybe make some changes in the short term or long term to better support them?
A couple of things come to mind. We talk about utilization management, and oftentimes that's got a tag on it that it's about cost. Obviously, cost plays into some decisions, but that's not the driver for the most part. So I would like to see manufacturers, when they bring products to market, maybe do a little bit more expansive clinical trials. We go so much off clinical information from studies when we look at that, and the broader patient population that they're able to do the studies in allows us to be more flexible in our criteria as well. So I think there's some room there for benefits. And then I do agree with the other two comments from the ladies prior about bringing the patient into that. We have a medication therapy management program. Those folks that have high utilization or issues, we can work with them through that program, help them with the prior auths, and walk them through that piece as well. So I agree there's probably some more work to do there, but we try to work in that space and assist some of those struggling members when it comes to something like that.
Yeah, good points too, to be looking to partner with our colleagues doing the research and making sure that they're bringing forward the evidence that we need so that we can make appropriate evidence-based coverage decisions. So I like that that point coming forward. So Emily, we're going to give you the final word kind of on what you would like to see in helping better address some of the challenges. I know you described a lot of very patient-centered work and programs that you all have put in place. So what do you see as a real opportunity to make a difference?
Yeah, thank you, Terry. I think probably the most important point that I would want to emphasize is just being prepared. Oftentimes speaking from a managed care organization perspective, there can be limited administrative resources available. And so just knowing what is coming and being prepared for any evaluation or analysis that's needed, and really taking advantage of the data that's available. Claims data and data available in a managed care organization is by no means perfect, but I think that using the data that you have available to inform your health equity programs can really be beneficial and help provide clarity and color to your points that you want to make in your organization. And then lastly, just thinking with gene therapies on the horizon, really being proactive with working with the manufacturers about possibilities for value-based agreements and, working to make those treatments more affordable on the back end.
Great points. At this time, I'd like to remind our audience to go ahead and put any questions that you have for our faculty into the comments section, and we can go ahead and read those out to them if you have any questions you'd like to get them answered. While we're waiting for those questions to come in, I guess, Dr. Jane, I'd like to go back to you, and maybe if there was one thing that you would like to see really change in the next 12 months, what would that one thing be?
So that's a great question, Terry. I think in the next 12 months, if we all unanimously work towards eliminating step therapy and making all disease modifying therapies equally accessible to patients with sickle cell disease, I think that is a goal that is very achievable with more education and awareness, and I think will really make a significant difference in the lives of a lot of sickle cell patients.
Good point.
Agree.
Francesca, you agree with that? Anything
Yes,
that you would add?
absolutely. Marcus is a complete example of why step therapy is not necessary. The day he died, he was due to start Adakveo, meaning he would have been on hydroxyurea, Endari, Oxbryta, and then he would have started in Adakveo. Unfortunately, the drugs came too late to mitigate the damage to his cerebral blood vessels. He died of a cerebral hemorrhage. But that speaks to what we need to do for those that follow him before they hit their 20s and 30s.
Yeah, great point. Well, I think we clearly heard today that with the increasing availability of new treatment options on the horizon and the ongoing disparities in care, there is really a need for the continued conversations, the continued education, and the partnerships to really find new approaches to mitigate access barriers and ensure that our patients can really achieve and receive adequate coverage for the treatment that they need. Our faculty have given us several recommendations, and they've outlined programs that they've used within their organizations that have worked well to better support patients with sickle cell disease. And at this point, I would like to conclude the webcast and thank Francesca Valentine, Doctors Jane, Catherine, and Seo for their excellent presentation and very insightful commentary. And once again, I'd like to thank Sick Cells for their support of this program.
Hello, everyone. I'd like to welcome you to our live session entitled Patient Journey. What does access and coverage look like for our patients? My name is Christina Reed. I am a Sick Cells Ambassador and the Executive Director for the Virginia Sickle Cell Network. I am also the mother of 6 wonderful children. 2 daughters, Olivia and Morgan, were both diagnosed with sickle cell disease at birth. For today's session, I will be joined by Ms. Ray Blaylark, Blaise Eppinger, and Chiffon Powell. It's my honor to introduce each of you today. Mr. Blaise Eppinger is a sickle cell warrior living in Georgia. He is also working at the Sickle Cell Foundation of Georgia and is a strong supporter of those living with sickle cell disease through legislative advocacy, in addition to camp counseling. Ms. Chiffon Powell is an adult warrior living with sickle cell SS. When she isn't busy being a mom to her 3 boys, John Jr., Marco, and Anthony, she supports advocacy efforts of her friends in the sickle cell community. She's a Washington, D.C. native and is happily married to her husband, John. Chiffon is not a stranger to her sharing her journey with sickle cell, as she has been featured in advocacy campaigns and videos multiple times. And finally, we have Ms. Ray Blaylark. Ray Blaylark is the founder and executive director of the Sickle Cell Foundation of Minnesota. She is the warrior mom of a 26-year-old son living with sickle cell disease. She has spent several years as the program coordinator of the state's largest pediatric sickle cell program located in Minnesota. Today's session aims to provide stakeholders with a more complete understanding of what individuals and their loved ones experience on a daily basis as they navigate the healthcare system and insurance coverage living with sickle cell disease and its treatments. Every insurer designs their plan differently through benefits, cost sharing, provider networks, just to give a few examples. However, in today's session, we will be discussing the overarching themes that are expressed broadly throughout the sickle cell disease community. The panelists will highlight major challenges that they face with their personal journeys as parents and or caregivers, and provide examples of opportunities for stakeholders to come together and reduce the burden of sickle cell disease for the sickle cell disease community. I'm sorry about that. I would like to invite each panelist to help set the stage for the rest of the discussion. In your opinion, let's talk about the persistent, reoccurring, or common problems that we face in the SCD community through insurance coverage. Ray, can we start with you?
Yeah, you certainly can. As the mother of a now young adult living with sickle cell disease, we've had 26 years of dealing with the insurance companies, and it's been quite the roller coaster. He was on a DAC-VO, but that took 2 years. Literally, it took 2 years to get through the approval process. The delays related to Indari were nearly 6 months. Both of those medications are critical to his ability to remain gainfully employed and to create a quality of life and emotional well-being that was not counterintuitive to his overall physical and mental health. As my son explained it to me on his 21st birthday, it's really hard to feel like you're growing into a man when you have a condition that tells you all the things you can't do as a man, and you're forced to be dependent on others rather than on yourself. So even that transition into adulthood, the transition into adult care was difficult enough, but that transition into being able to embrace your adulthood as a man was equally difficult because of the challenges after challenges of not being able to get on medications, not being taken off of medications. In addition, like because of the challenges, just maintaining his overall wellness, I found myself that even as a parent of an adult child, needing to take countless days off to provide caregiving at those times that he was unable to care for himself because he was in another crisis, because he wasn't on the medications he needed to be on, because of the delays that caused anxiety and triggered his sickle cell disease. This put a huge strain on the entire family, not just myself, but my husband, the other kids in the family. There was the financial burdens professionally, and how that impacted my work professionally and the missed days, but also emotionally and then relationally between he and I. There were just a number of challenges that came about because he either couldn't be on the medication that the doctor wanted him to be on, or he had to stop a medication because of challenges with the insurance.
Thank you, Ray, for sharing your story. What it's like raising and now being a parent of an adult warrior and the challenges that you still face, especially as it relates to caring for your son with sickle cell disease. We're going to go on, and Blaze, I would love for you to kind of tell me about what you may be experiencing as an adult living with sickle cell.
To speak on what Ray spoke on about a little bit, not being able to access other things that you may need with sickle cell has always been a problem. Before I started working full time, I was on just Social Security. A lot of people who may have illnesses and disabilities are on Social Security, right? So along with receiving Social Security, you may receive Medicaid. I feel like it's a lot of gaps that are, within those two programs. Because if you know I'm on Social Security, my income is not that great. And then if I'm on Medicaid, I can't possibly afford the things that Medicaid doesn't cover, if that makes sense. For example, if I need to go to the dentist, Medicaid only covers extractions. It doesn't cover the care of your teeth. And then they tell you things like, oh, well, you would have to cover these expenses out of pocket. How am I going to be able to afford these expenses if I'm on Medicaid and I receive $700 a month or $800 a month, which isn't enough for someone to live off of? So growing up, when I was on Social Security, that was pretty difficult for me because it was like there would be things that I would need for my teeth, fillings, cleanings, things of that nature. And it's like, do I take the little money that I'm getting from this program to survive, or do I take it and put it towards my teeth? And it was always kind of like give and take. So that was difficult in itself. But to speak more to more recent, my journey with Adakveo. At first, it was like a big limbo to try to get on drugs. And as most people in the sickle cell space know, there are a lot of different treatments on the horizons. So this was my first attempt to get on a new drug, and that was Adakveo. And it was very difficult. It was the insurance didn't know if they wanted to cover it. And then I had got started on it after some time. And then one day I went to my daughter's office, and it was like, your insurance should stop covering it. And I'm like, why? And they didn't really have an excuse or nothing. They just said, hey, they're not covering it anymore. So my doctor had to write a letter, and then they start covering it again. But it's just like, these drugs are here to help us better our lives, So why is it so difficult to ask? And then
I'm sorry,
as
Blaze. I think
Medicaid playing around where it's like, okay, we'll cover it, but no, it's too.
Blaze. I'm sorry. I think that there's some difficulties with your connection.
Right.
Are you able to hear?
Still,
I'm sorry.
can you hear me?
Yes, I think we can hear you now. Could you go back to your doctor having to write a letter in order
Can you
for you
see?
to? Yes. Blaze, maybe you can hop off and then come back on.
Okay. No, can't hear me. Gotcha.
Okay. So it looks like he dropped off. But where we were headed, Blaze was kind of talking about how his insurance was no longer going to allow for him to receive his medication. And his doctor kind of had to write a letter stating the need for him to be on the Adapvio. Shafan, have you experienced any similar situations where you were unable to access a treatment that you needed?
Yes, I have experienced similar to what Blaze experienced. So I too started Adapvio. My hematologist thought that would be a great treatment for me, especially because the side effects, it didn't include headaches, so that was great. So for me, getting approved, that wasn't the hard part. Like I got approved as soon as it was approved. It was FDA approved, so it was like immediate for me. However, I began to receive my treatments, and I was doing great, and quality of life improved and everything for about 6 months. And then I went in like Blaze for an appointment. No one called, notified me or anything. I went into the infusion center and I was informed that my insurance wasn't going to cover the medication for the infusion. Um, and it kind of devastated me because there was no explanation given. I didn't know, why they just decided to stop um, the access of that medication, to continue to provide the medication for me. However, it was a little disturbing because they could see, like, over that 6 month time, I was improving. I had no hospitalizations. I had no admission. I mean, I had no admissions, no crisis, no, not even my at home pain. Like the Adapio was helping me significantly um, with a higher hemoglobin and my overall pain, acute and chronic. So it was just a little frustrating that they did decide to discontinue my medication. But like Blake stated, my doctor advocated on my behalf. And however, that's where the challenge came because it took about 3 months for them to I guess, reinstate, or I'm not exactly sure the terminology, but for them to actually um, allow me to get that medication again. And during that 3 month time span, I was hospitalized quite frequently, like more than usual. Like in that 3 month time span, I may have been admitted maybe 6 times. So yeah, that was pretty devastating just to be denied that coverage for a medication that was actually improving my life, improving the quality of my life.
Yeah, Shafan, that is disappointing to hear that these delays are happening for treatments, especially for treatments that have been on the market for many years. Blaze, I know you had to step off, but could you continue? I believe we stopped off when you were discussing your appointment and your doctor advocating for you, kind of like he did for, Shafan's doctor did for her.
Yeah, my doctor had to seek out and see why. It didn't take as long as Chiffons. So I came one appointment. They said it was unavailable. I asked why. Insurance said they wasn't going to cover it. He did some advocating for it, and then the next following month, I was able to get it back again. But it was just random. It was you go in for your treatment, you're expecting everything to be normal or whatever. And then, your insurance just basically just says, we changed our mind. So.
Wow. Yeah. That is, I'm sorry, Ray.
Oh, I was just going to say that's such a similar story amongst, people with sickle cell disease, because I remember at the beginning of the pandemic, which was when we were starting our Adakvio journey, and my son was actually very excited, which he's not typically excited about starting taking meds, but he was actually excited because he felt like it was going to change his quality of life, that he was going to be able to do more of the things he wanted to do. And because of that delay, I remember him getting admitted into the hospital. And at the time he had 2 jobs. He had a full-time job and he was trying to work a part-time job to save up to buy a car. And he ended up in the hospital, and he ended up actually losing his job because his second job he hadn't been on long enough to get the benefits. And yet he couldn't get his health under control by just simply taking his hydroxyurea. It just wasn't enough. He needed that extra layer of protection. And losing his job after a hospital stay, it's difficult enough to get back on that horse and ride it after you get out of the hospital, but to then be discouraged and a setback, not just the typical setback of after the hospital, but a major life setback that really disrupts how you were planning to live a quality life. It does impact you. And then what do you put on your next job application? How do you explain that, if there's a gap in work or they're asking you why you no longer work at that place? It was tough on him.
Yeah, I can understand that, definitely. In an earlier discussion I was in on, someone used the term humanizing, making a person have dignity again, a person who's living with this chronic illness have dignity again. And that's true. If you're losing your job, which could potentially provide private insurance for you, which in turn probably would give you more treatment options, or whatever the case may be, because everyone's insurance coverage varies. I can completely understand how devastating that would be for your son, or you Blaze, and you Chiffon. While each of you have powerful examples of challenges that you've all faced, and more of our community members face as well, I'd like to hear more about how these complications have impacted your lives. Ray, you just discussed how it impacted your son's life. Could you let us know, as a caregiver, even though your son is an adult, how did that impact your life?
Oh gosh, when my son was younger, of course, it felt like insurance was a breeze, actually. That, there were few hiccups, and the medical team was always Johnny on the spot with regard to approvals and authorizations. Even though I'll say over the years we've spent countless hours on the phone dealing with insurance barriers, it just was it was very different. It's very different now because there's more options than 20 years ago when my son was small. So there's more barriers. And even though I've always taken advantage of the teachable moments to show him how to navigate these various systems, once he became an adult, much of what I had learned and what I was teaching him felt irrelevant because of the constant challenges with the prior auths, the denials, the step therapies, and all these other unanticipated delays that challenged his health rather than improved it. So it was really disheartening when those treatment options began to improve, but access to those options created additional barriers that overshadowed the celebration of the progress we were making as a community, but even as a household. So as a caregiver, it's really difficult to have a discussion with your child of any age when you're focused on providing hope and encouragement about the life they're living. And yet you also have to have these really, again, discouraging conversations about what they can't access, what they can't do, the additional days they'll have to take off of work, how to fill out additional paperwork, who to contact, because now, the employer has this expectation, or you've already exhausted all of your days off, and you're working on a point system and you can't afford to take any more points. All of those things begin to really play a role in my son's mental health, and I'll be honest, in my own mental health. And I think that's what it feels like that people don't always take into consideration. It's like no one takes into consideration the mental and emotional toll of living with a chronic illness and navigating the barriers that keep you from living your best life. And that is the person living with sickle cell disease first and foremost. But those who support that person, it's impacting their quality of life. It's impacting their mental and emotional health. It's even impacting the relationship between the caregiver and the person living with sickle cell disease. It's impacting the person with sickle cell disease and their siblings because of the attention and the time that's having to be taken to address that child's needs. So, it's sad and it's frustrating when mental health suddenly becomes a comorbidity, in part due to systemic barriers to that impact quality of life.
Wow, Ray, you have touched on so many points that every one of us, as well as other members of our community, can associate with. We can relate to it all. And I know for me, my girls, they have had subsequent complications due to having sickle cell. So we lived in Georgia, and they had pneumonia often. It's humid in Georgia, and they had pneumonia often, and subsequently there was scarring on their lungs, which now they're on asthma medication, and and with asthma, and my kids are still school age, you have your medications at home and at school, and insurance the copay is expensive, especially for us. We have a big family, and while my husband, he happened to be at this job so long, he was grandfathered into an amazing insurance policy, so we had good coverage, but it hit us like very hard, because here we are, we have what we normally have to take, then what we have to take now because we've developed something else, and then not only that, we have to provide 2 medications for the different locations of where my children are. So yeah, everybody has a story. So Shafan, we'll go to you. You mentioned during the periods that your insurance denied your treatment, you ended up in the hospital quite frequently.
Yeah.
I believe you said 6 times in 3 months?
Yeah.
Yeah.
Now, all of those weren't admissions, but they were, I think it was about 4 admissions and maybe like 2 ER visits.
Yeah, that's a lot, Shafan.
Yeah,
That's an
that is.
interruption, especially if you were saying that with the treatment, you were having a better quality of life.
Yeah.
So how did that affect your family? You're a mom of 3 boys and you have a husband, you got things going on in DC. I'm sure, how did that affect your life personally?
So it affected us greatly. It kind of really put me into like a really bad depression. Because around the time that I was getting sick, there was events going on, it was holidays, it was birthdays, and missing out on those special moments with my children, you can't get that back. That's something, you can't put value, you can't put a price on. It's priceless. So missing out on that time with them, it put me into like a really bad depression, and my mental health was more affected when the coverage was denied, when I got off the Adakveo than it ever has been. So, me being a wife and a mom, I'm also employed too. So, sometimes employers, they are considerate, And there's all kinds of leaves you can take, FMLA and things like that support you. You can take your sick leave. However, over a period of time of being consistently, absent from work, you lose your job. So that's an area, that's frustrating because then you're not able to finance your family. You're not able to do things with your children that you normally do because the money isn't there. And then with my husband, like Mrs. Ray said, um, it's difficult for the caregiver because everything goes on them, and my house is one unit. And when I'm not there, it's like chaos. So, my husband, he does the best that he can. And he's amazing. He's great. But it's nothing like mom being there. But mom can't always be there, and my children, the ones that's up in age, the 16 and 10-year-old, they're very understanding and very compassionate. Like, although I beat myself up sometimes when I miss out on those important milestones or special occasions with them, they always say, Mom, you can come next time, or, we know that you're sick. We don't really understand why children are so compassionate and understanding, but my children, they definitely keep me going because while being hospitalized and you're away from your family, it kind of ruins everything about your life, your what you're experiencing. And then if you don't have a support system, that's another thing that you have to look at. My support system is really small, but say for instance I didn't have my husband or I didn't have my sister, you know I don't know how I'll be able to do it.
Yeah.
It's extremely difficult dealing with sickle cell and dealing with it alone. You have
Yeah.
to have a support system.
Absolutely.
Important.
Yeah, so that Shafan, that is so true. And moms are, my husband says, we're the nucleus of the family. So you're right. Blaze, I just want to touch a little, very, very briefly on, you mentioned employment and how, before you were on SSI and then now you're employed with the Sickle Cell Foundation of Georgia. Can you talk to me a little bit about that change?
I mean, full transparency, I just thought that's what life was going to be for me, just being honest. Because, like Ms. Ray said and Shafan, you're hospitalized so many times that no matter what job you take, it's kind of like, it won't last, especially if you don't have somebody, I guess, in that managerial position or supervisor position that understands sickle cell. Like I have one job before this job where I worked at Forever 21. I was young, and the supervisor, her ex-husband had sickle cell. He had passed. So when I told her I had sickle cell, she was super understanding. And it was like, it was a relief because before that, it was like hospitalized, got to go, whatever. So everybody always says they understand in the beginning.
Yeah.
And then once it starts happening, it's like, oh, they don't understand really.
Yeah.
I guess because that's a nice thing to say. So I started volunteering just because one of my friends told me to at sickle cell camp, which you spoke about earlier. And the camp was an annual camp that we have called Camp New Hope for kids living with sickle cell disease, age 7 through 17. And so I always wanted to go to camp when I was young, but I wasn't able to because of just family issues. So Sean, that was his name. He was like, man, you should just come to camp. It'll be fun. You won't get the child experience, but you still get, being around a whole bunch of people with sickle cell and, family experience. So I did it and I volunteered and I was a camp counselor. And so the following summer, Sean died. And so I had a choice to keep going to camp and keep doing what Sean wanted me to do, or I could have just, stopped. So I kept volunteering, just here and there wherever I could. And then a job opened up.
Yeah.
And then I started advocating heavy, started going all over the place, met Ray, met Shafan. And I've been advocating ever since. So initially I was scared to work because I was thinking like, okay, they offering me a full-time position, but if I get sick, whatever. And so then that was just a fear, but they had never said anything like that. And besides, it's Sickle Cell Foundation of Georgia. You think if anybody would be understanding, it would be a foundation that knows you have sickle cell. So I stayed part-time in the beginning because I still was scared. And then I would still have my SSI to fall back on. But then I just took a leap and I was just like, I can work full time and I can be healthy and I could, and so that happened before Adacvio. And then Adacvio came around and now I don't get sick anymore. I don't have a crisis where I get hospitalized. So I don't miss time like that no more. I missed time twice this year. And that was because I caught COVID one time, which, what am I going to do about that? The COVID mixed with my sickle cell was just going crazy on me. And then I had caught pneumonia. And so, but as far as just like, what used to be the run of the mill, having a crisis, going hospitalized, that doesn't happen for me anymore. And it's because of Adacvio.
Oh, wow. That's good to hear, Blaze, and congratulations. We, we've heard a lot of the challenges that we face and we know our community faces. Right now, I'd like to see if you all thought, maybe I can just hear one from each of you, of a strategy or scenario where good coverage or care by your insurance provider is beneficial. So if we can just go through that and then move on, and we'll go into their Q&A. Go ahead, Blaze.
I'll just go. Medicaid has helped me, even though it has downsides to it. Like one time I saw an actual bill of what accrues when you have a crisis and you receive all that medicine and the waters and the things you think that, you're not getting charged for, you are getting charged for. So I've seen one of those bills before and I was just thinking, Jesus Christ, what if I didn't have Medicaid at all, So I would say that that's super positive. It has helped with, hospital visits. Whenever I am hospitalized for all those days and stuff like that, I haven't accrued a bill besides one time though. And that's when I was going to do some speaking for sickle cell, but it was in North Carolina and I got sick there. And I didn't know that my Medicaid didn't cover because it was a Georgia thing. So yeah, they had sent me a $3,000 bill and I was just,
oh, wow.
But yeah, that's been beneficial.
So Medicaid, yeah. And what about you, Shafan?
So I have Medicaid and Medicare, and I feel like the most beneficial to me is
Alexander, please come to Cheryl's desk. Alexander, please come to Cheryl.
Hello.
Sorry. Yes, we're back.
Okay,
Shafan.
I thought I had interference. I'm sorry. But yeah, I think for me, I believe, I don't know how to explain it, but I think the best thing for them with the insurance coverage is just admissions.
Yeah.
Like and I know it's a law, and it can't deny you if you're coming into the emergency room. That's not going to happen. But like, I know when I go into the emergency department, I know there's not going to be any second guessing or questioning, because it's going to be covered. And I've been so grateful to have, I've had private insurance with previous positions, and I had to pay a copay every visit, every ED visit, and things like that. So I can say with the Medicaid and Medicare, I don't have to, make co-payments or anything like that. So that has definitely been beneficial.
Ray, what are your thoughts?
Yeah, Medicaid does have its advantages, and some of that is related to the burden of care, the burden of cost of care. And so when that does work, and Shafan, you hit the nail on the head, with particularly in hospitalizations. My son is not one that likes to go to the hospital, and even less to the emergency room. So, when we go, it's absolutely necessary. And unfortunately, he has a very complex phenotype of his sickle cell. So I too, have seen a few of those bills, Blaze, and I have literally been like, wow. And I remember there was one bill that was, it was over $200,000 for his hospital stay. Not to mention he had spine surgery because he had a fractured spine, which was causing him to have more sickle cell pain in his back and inflammation. And the cost of coverage for that, which had lapsed shortly before he was scheduled to have his surgery. I remember I was on the brink of losing my job because I was spending so much time on the phone. And I remember that we encountered this nurse navigator who was incredible. She literally, it was as if she took our hand and just walked with us every step of the way. Excuse me. And it wasn't just that she was making phone calls on our behalf, or she was writing letters on our behalf, or the appeals, but she was keeping us informed about what she was doing. So the stress that I was carrying as a caregiver, knowing that, excuse me, knowing that, my son's ability to walk was dependent on this surgery. One less thing I had to worry about was, where are we in this approval process? Because she maintained that communication. So the nurse navigators, those patient navigators, are really, really priceless when they are able to do their job, and they're knowledgeable about the process in which they're helping you to navigate through, right? So that was huge. The fact that she could maintain this communication with the physician, we could reach her quicker than we could reach the physician. So she was that line of communication for us. In times past, like I said, there's so much volleying of responsibility of whose fault it was, who this should go to. You are literally a volleyball in the medical system. And it was helpful for my son to hear those challenges from her as well, because she was able to explain them in a way that at that time I didn't fully understand, but we were also able to learn how to take what we were learning and apply that to future issues that have come up since then. Now, in addition, she was recently, we fought to keep her, and she's been able to help us start the approval processes that are needed so that he can get access to mental health and adjunct therapy support that enhance his holistic health. Because even though you have sickle cell disease, you are more than your sickle cell disease. I love that Blaze brought up about, oral hygiene and making sure that you can get those things done. There's so many other pieces, reproductive health, all of these other pieces that are part of just your humanity. And sometimes you get put into this box of just sickle cell, just pain, but there's many other complications and many other collateral things that happen as a result that impact your health as well. So one of the things that I really like to reinforce is that it's not quality of life in the way that the medical system and Medicaid and Medicare and all of these HMOs measure it is often because you're alive. So you must have quality of life. But it's so much bigger. That's quantity of life. And there's more to life than the quantity. It is the quality. And quality isn't defined by any one particular, body of being. It is defined by cultural values, individual values, community values. There's so many other things that go into quality of life that have to be taken into consideration. The ability to continue working, the ability to speak up on your own behalf and to advocate for yourself and to have some wins, right? If every time you advocate, it seems like it never works on your behalf, it does affect the rigor in which you feel that it's successful. So it is important that as we see improvements in options for caring for sickle cell disease, that we don't create more barriers by accessing those achievements. And so we have to make sure that we keep our eyes on the prize, and that we recognize that for one solution, we don't want to inadvertently create 3 more problems, because
Absolutely.
everyone is affected.
Yeah, absolutely, Ray. I love how you mentioned holistic health, whole person health. And as everyone has spoken and touched on, having sickle cell disease affects your blood and every other part of your life, including your mental health, including your oral health, including your lung health, including your relationships, your abilities to make friends. You know, when my children were younger, if they were hospitalized, they would come back and their friends had moved on to another group of friends. And all of that is difficult for all of that is difficult for you as a caregiver to see. And, especially if you have mom guilt, because you've passed on your genetics that has caused this disease. But let's move on. At this time, we'd like to conduct our question and answer session. If you haven't already, please submit a question in the chat box of the screen, and we look forward to answering them.
I did see that Maggie had wrote a question, about some of the coverage for other areas.
Yeah.
And I think that's something that we're still struggling with. And I think that goes back to some of my comment about making sure that we're seen as a holistic person, and that, Western medicine is wonderful, and there's many countries that vie for access to Western medicine, but there's also Eastern medicine practices that are not yet covered under traditional insurance that are incredibly beneficial. With my son with having an added back issue, being able to go to the chiropractor, being able to get massage, being able to do, those are things that for years I've had to pay out of pocket for him to get to. And Shafan, summed it up beautifully. That means that there's other things that we're not going to be able to do. To have to choose between, okay, do I take the kids on this vacation, or do we have this outing? Are we able to do our once a week, out at a restaurant or not? Is dependent on how much out-of-pocket costs we're going to have, that really in actuality should be covered by insurance, because it does have to do with our overall health. And so my ask is really that we begin to look outside of the box, that we open up our scope of understanding of what good care looks like, what quality care looks like, and that we move outside of just the traditional profit-making ways of determining, but that we all look at all of the ways that we can impact health.
Thank you, Ray. Maggie asked, Blaze, she asks, but you just answered. So she asked that Blaze spoke about not having coverage necessary for dental care. And she asked if any of the other speakers ever had any challenges receiving coverage for other necessary health services. And Ray, you spoke about massage therapy, and you were previously paying out of pocket, and now that is accessible through your insurance cover or your son's insurance.
We're
Am I
still
right?
trying.
You're trying.
To get that.
I see.
Yes.
Yeah. What about other? And you spoke about Eastern medication. I see that there are a lot more pain specialists who are advertising their services, especially to the SCD community. Have any of you ever been able to access any services from pain management specialists who work in a holistic, who provide holistic services?
So I have received, the answer to your question, no, not in the holistic way, but I have received pain management services through my hospital. However, the mental health services are not included in my insurance. So that's an out-of-pocket expense. they have some, that's in the network, but you definitely don't want to use them when you're looking for a specific outcome, when you're, seeking mental health services. So my mental health services has always been denied. They've never covered that.
Okay, well, we have come to the end of our session. I'd like to again thank you for having me, Christina Reed. Thank you, Ray Blaylark, Chiffon Powell, and Blaze Eppinger, just for sharing your stories. And I believe that the impact of your stories will improve so much quality coverage and everything that Sick Cells is pushing and advocating for. Thanks so much, Sick Cells, for having us.
Thank you for having me.
Hi, everyone. Welcome back. We're going to go ahead and get started with session 4, a managed care approach for sickle cell disease. I'm going to go ahead and introduce our speakers, as our moderator is having some technical difficulties, but I'm sure we'll get her in here shortly. Thank you all for joining. We have 3 speakers on today's panel, and I'll go ahead and introduce them. So we have Mr. John Stansel, Dr. John Watkins, and Ms. Chanel Grismore. So it's my honor to introduce each of them to you. John Stansel has more than 10 years of experience in state Medicaid pharmacy administration and pharmacy benefit, which includes 5 years of experience as the pharmacy director for North Carolina Medicaid. He's currently at RTS Solutions, and he's responsible for providing account management and operational support for new drug launches, assisting with nationwide and individual state strategy development, payer engagement, and post-launch pull-through. Thank you so much, John, for joining us. The next panelist will be Dr. John Watkins. He managed the formulary process at Premera Blue Cross from 2000 to 2019. He is currently the director of Premera's Managed Care Pharmacy Residency Program and manages the Pharmacy and Therapeutics Committee. Last but not least, Chanel Grismore serves as the director of the Sickle Cell Center at Loma Linda University Medical Center. In her role, she oversees the administrative, financial, and operational components of the Sickle Cell Center. The overarching session goals will be to discuss sickle cell disease managed care strategies, and each of these panelists can offer different expertise and perspective to help us understand the value of and potential trade-off for managed care pharmacy and services. Session, we're hoping the audience will be able to identify solutions to close SCD care gaps with managed care organizations. Thank you all for joining us. Let's go ahead and get started.
Okay, Emma, thank you again for your introduction and for Sick Cells allowing me the opportunity to present today at this conference. Go ahead and move to the next screen. And as Emma said, I was formerly the pharmacy director at North Carolina Medicaid, but I think it's also important to note that when I left North Carolina Medicaid, I joined Global Blood Therapeutics, who introduced a new drug therapy for sickle cell disease in 2019 and had a 6-state region that I worked with different payers on getting access to that therapy. My slides today, I want to talk a little bit about the approach to engaging managed Medicaid and maybe a more effective strategy around doing that. Some of these numbers here, probably you've seen before, that there's approximately 100,000 people in the United States that have sickle cell disease. Therefore, it is considered to be a rare disease, and because it does affect people less than 100,000 people in the country. The incidence of sickle cell disease, you've seen these numbers for Afro-American as well as Hispanic American. And it's important to note here that this disease has no color. You'll meet with a lot of providers, payers, and they all think this is a disease that only affects the Black, Afro-American Black population, but that's not the case. Also, that you probably did not know that more than 55% of the people that are living with sickle cell disease reside in just 10 states within the country. And you can see what those 10 states are and the population of sickle cell patients within that state. for a total of about 55,000, which is a little bit more than half of the population. Next slide. As far as the pharmacy benefit coverage, you can begin to see how this would be a daunting task. You've got some really large states here in terms of Medicaid population. The Medicaid population, with the expansion due to the public health emergency, now is about a little over 92 million people that are receiving or covered, their health benefit is covered by Medicaid programs. But you can see here that in a state such as Florida, where there is a total of a little over 5 million lives, most of those lives are in managed care, and which that means there's two types of programs in most of these states. There is the fee-for-service, which is your traditional Medicaid program, and then there's the managed Medicaid program, where a lot of states have moved to a more budget predictable model where they contract with commercial health plans that have a managed Medicaid component to their business unit that will provide those Medicaid benefits for that state's population. And they receive a set amount of money that they have to manage the pharmacy and medical benefits for that benefit within that state. And so you can see here that this represents probably approximately about 75% of these lives are in the managed care environment. Next slide, please. Okay. Like I said, if you look at the total Medicaid population, there's almost 92 million covered lives now in the Medicaid population. I think it's also important to note that when I was with Global Blood Therapeutics, that most of our patients, or most of the patients that we had on drug, were covered by a government-sponsored health plan, meaning either Medicaid or Medicare. So this is my topic, or my conversation today is going to really focus on the Medicaid space. And so you can see that 75% of all Medicaid covered lives are in managed care, in a managed care plan, meaning that their medical and pharmacy benefits are assigned to those managed Medicaid plans within their state. Next slide. But as you start to look at the top 10 states where most of the sickle cell patients reside, that number actually increases now to 81%. So in those top 10 states, if you look just across all Medicaid covered lives, 81% of those lives are covered by a managed Medicaid plan. Now, while this becomes a daunting task as far as engaging these payers, is that if you look at just the top 3 Medicaid states, if you'll step back to the previous there, if you look at the top 3 states in terms of their total Medicaid lives, you're looking there, and if you throw in California, you're actually looking at over 100 managed Medicaid plans there. And so to begin payer education, payer engagement, that's pretty daunting just in 3 or 4 states. Now, if you multiply that across 50 states, then you can see how that number would quickly increase. Okay, we'll move back up to slide 8, I think it is. Okay, but the thing that when we look a little bit closer, if you look at those total Medicaid lives, where there is approximately 92 million, almost 92 million lives, but in a lot of those states, though they are in a managed Medicaid model, the state has actually pulled that control for the pharmacy benefit back over to the state fee-for-service program, meaning that the managed Medicaid plans either do not have flexibility, and the state has carved out the entire pharmacy benefit, meaning that they cover the pharmacy benefit for all their covered lives, or either they have a statewide preferred drug list that all of the managed Medicaid plans must align their formularies to. And so while 75% of total covered lives in all of Medicaid are assigned to a managed Medicaid plan, actually 79% of those covered lives are really controlled by the state where they live. Next slide. And then if we want to look at just those top 10 states where the majority of the sickle cell patients reside, you can see that that number does decrease slightly, but it now changes to 77%. So instead of looking at states, just those 4 that have over 100 managed Medicaid plans, we can actually now begin to start focusing only on that state fee-for-service program, which is going to determine the coverage and the access for all the patients covered, regardless if they're covered by the state or if they're covered by one of the managed Medicaid plans there in their state. Next slide. I think we all know that the prevalence of some of these other inherited rare diseases in the country, there's smaller numbers, but they get a lot more attention. There's been a lot more research dollars. You call on payers. They're a lot more educated and familiar with the drug therapies, the impact of the disease on the patient and the families and the caregivers for those patients. But that's not the case with sickle cell disease. And I came to realize that very quickly in my role at Global Blood Therapeutics, that this was a disease that a lot of people didn't know about. Either they may have had a patient when they were in residency training, or they've never cared for a patient with sickle cell disease. So this was all new to them. And this is why it's so important that we educate. Next slide. These are things that were insights when not only from a Medicaid payer perspective, but also when I transitioned over to industry working with Global Blood Therapeutics. Payers in general are not deeply familiar with the clinical aspects of sickle cell disease. They don't know what really occurs. They have a basic understanding or belief in what they think sickle cell disease is. Most of them think it's a disease of vaso-occlusive crisis or pain crisis. They look at this as a disease that has a lot of ER visits due to pain. And so that's really the extent of their knowledge or their understanding of it. Although they are aware that hydroxyurea is the standard of care, and they do know about Endari, none of them really could speak to the details of their efficacy or their safety, or really actually how they worked in the treatment of this disease. But payers also consider sickle cell disease to be a severe, high-impact disease with significant patient burden and remaining unmet need. I think it's key here to point out that a lot of, because a patient is covered by Medicaid today, doesn't always mean they're going to be on Medicaid forever. It could be that they become employed, they lose their Medicaid benefits because of some situation or change in their life. So they're not always on Medicaid. But there's the same thing as on the commercial side. So a payer, if they look across and say, well, how much are my patients, they identify all the patients with sickle cell disease, how much are they actually costing me? They may not see a lot of cost other than ER visits, and they're trying to reduce that and say, you need to get your primary care in the physician's office instead of the hospital emergency room. But they don't, I think that creates an opportunity to share with them that access to specialized care is not readily available, especially in rural areas of most of these states. Payers are also not aware of the cognitive impact associated with sickle cell disease. Sickle cell patients are generally believed to be receiving treatment from a specialist or a sickle cell disease expert. When policies started to be developed for the 2 new drugs that were introduced to the market in November of 2019, there were payers that were requiring these to be prescribed by a specialist. Well, I had South Carolina, for example, and one of the treatment centers there at the Medical University of South Carolina, their medical director is actually not a trained hematologist. That medical director for the adult clinic there is actually a practicing psychiatrist and divides her time between the behavioral health clinic, 20 hours there, and then 20 hours in the sickle cell disease clinic. So we were able to educate providers to make them understand that access to a hematologist is not always available And would they consider either removing that restriction or that requirement, or either adding to the either be a hematologist or a physician with specialized training in the care of sickle cell disease? And then some payers do not believe that sickle cell patients have difficulty in accessing specialists for treatment, even if they're covered with Medicaid. A lot of Medicaid payers say, look, we cover, as long as they're an enrolled provider, we will pay for, they don't have to have a referral like you do in the commercial space, but they don't understand that, either because of travel distance or the lack of those specialists in their immediate area, that's not readily available. One of the other things that was unique about South Carolina is actually their legislature in 2019 actually appropriated monies to conduct a study of access or care for sickle cell disease there. And one of the findings from this study was that there was a lack of treatment providers and care available to sickle cell patients there in their state. The unfortunate thing, I think, I really do believe that this study was paid for. It was done as it was required to be done by the Medicaid agency there. Excuse me. And then it was put on the bookshelf and no one ever picked it up again. One of the unfortunate things about COVID was that it kind of shut down a lot of advocacy activities. You couldn't get before people or in front of people. And so things like that maybe they've been forgotten. They need to be resurrected, and we need to revisit those things that have been done. Next slide. And the payer world, and I'll just be realistic. When I was a payer, and a lot of payers, you'll see this among whether they're Medicaid, managed Medicaid, commercial. If a drug therapy is going to cost $100,000, they want to make sure that it's used appropriately, safely, and that they're not spending money where they don't need to be spending money. Just because a drug costs $100,000, the reality is it doesn't always mean that drug works better than something else in many cases. So you can see here that as our job was to create access, and you have to understand that I think it's important to first define what does good access look like. You want to minimize the barriers to patient access. There's going to be a prior authorization, or a lot of times there will be prior authorization, but also understanding what those prior authorization requirements are so that you can help that provider when they're requesting a prior authorization, so that they submit the information that's needed. They don't get rejections and it ends up in an appeal, which takes even more time. And then you can see on the payer side, some of the utilization management strategies or prior authorizations that they will require. They'll require step through or trial and failure. The drug hydroxyurea is a very cheap drug. It's been out on the market for years. It's a generic formulation. It probably costs $30 a month, maybe. And so obviously when our drug came out, they wanted to see that the patient had at least tried or there was some reason or contraindication. I will tell you that Medicaid always tries to provide the patient and the provider with the medication they feel that is best for that patient. So if the provider will give sufficient reason, a lot of times those PAs will be approved upon request. They want to receive a response to therapy. They a lot of therapies that are going to cost $100,000. They want to know it's working. They also want to see that the patient is actually taking it and is being compliant. So I think that's why it's important also to have services built around to improve or enhance compliance to medications. I don't care how good the drug is. If the patient doesn't take it, it doesn't work. And then formulary exclusion. That's the worst form of restriction, where basically it's not covered. You're always going to be having to justify its use, but you almost have to be careful there, because medical necessity justification sometimes can be a better path forward than actually a state or a payer developing criteria, which might be even more cumbersome. Next slide. Some of the algorithms for success, and I'll go back to our topic about education. This is a fragile patient population. Their disease is very complex. Every organ system within a sickle cell patient is impacted by this disease because of the lack of oxygen. The clinical value, that's so key to demonstrate what the value of this drug or what the drug you are trying to access is going to offer for this patient. In terms of their association of anemia and how the anemia can affect other organ systems, as well as the general feel of the patient and their cognition. Also, I think it's important to have those discussions around quality of life and their life expectancy and death. Also, payers want to understand the economic value. While they may look at a snapshot in time of how much their patients with sickle cell disease are cost them, you have to make sure that they understand that if you're not taking care of the patient appropriately now, that cost is going to go up a lot more because they're going to be in the hospital. That's where the most expensive care is being rendered. And so you're trying to avoid that disability and those hospitalizations down the road. And then I can't stress this enough. Because this disease does not get the attention that some of the other rare diseases have gotten, everyone from the manufacturer to advocacy, everyone has to make sure that the sickle cell patient has a voice. We have to be advocates for our patients. And one of the things that I did encounter at Global Blood is how passionate people are. Some of the providers I met were incredible. And they didn't let off the pedal. In Virginia, I had a physician, Dr. Wally Smith, that was at VCU and in charge of the adult sickle cell clinic there. We had a managed Medicaid plan that was actually more restrictive than the state. And he pretty much demanded that he wanted to have a weekly meeting to discuss every patient that plan denied. And it was only about the second meeting that he said, okay, help me understand. This patient, regardless if they're covered by the state or your plan, they're a Medicaid patient. But if they were covered by the state, this request would be approved, but it's not being approved by you. So I need to have a better understanding of that before I call my legislator and help and explain this to him. Well, they decided to throw in the towel and align their criteria with what the state, and they lifted a lot of the restrictions. And they were able to streamline their process using staff in their office so that they made sure that the right materials, the right documentation, everything was submitted so that the PA could be reviewed and approved on first submission. And I thank you, and I'll be glad to take any questions at the end that you may have.
Thank you so much, John. We'll go ahead and move right into our second speaker. And I wanted to note that if you do have questions that come up during these presentations, feel free to pop them into the Q&A and chat box. And we'll have the moderated Q&A and discussion at the end of all of the presentations. So without further delay, John, I'll hand it off to you. It looks like you are still muted, so you might need to unmute yourself. Should be down at the bottom left.
Yes. Sorry.
There you go. Okay, now the floor is yours.
Thanks to everyone for inviting me. In my position, people like me want to help, but we don't know what we don't know. And I'm going to, rather than just giving you a canned spiel, I want to make some comments on some of what I've learned and some of what I've heard today. And then we have time for a discussion. I see we're a little bit behind schedule, so try not to take too long. I should put a disclaimer here that, just to be clear, I am speaking as an individual. My remarks should not be construed as representing any official positions at Premera Blue Cross, but I have worked there for a long time and have the ability to also sort of step aside and look at them from another angle. So I went to school nearly half a century ago in pharmacy school, And we weren't taught much. Actually, I think we had one probably 50-minute lecture on sickle cell disease, and they didn't tell us much. That's probably not a slam on the school, because pharmacy education tends to focus on conditions that we have drugs for. And we didn't have any drugs for SCD at that time. So next slide, please. I learned about all this end of 2019, beginning of 2020, and it was ICER really that introduced me to the subject. I know some of you have mixed feelings about ICER, but they do a lot of good work in terms of bringing together patient advocates and also the providers that take care of patients with rare diseases, and just educating the rest of us. So when I saw the ICER report, I was shocked. Things that stood out to me, basically the fact that multiple people that they talk about not even wanting to go to that emergency room because you're going to feel judged. They look at you and you don't want to look back. One person said finding a doctor in the emergency room that knows anything about sickle cell is like finding a needle in a haystack. And then the one that really got me was a white collar person saying that they had to stop and put on their professional clothes to go into the emergency room so that hopefully they would get taken more seriously. So I came back from that with the desire to do something about this. And if you heard Emily earlier, she told you all the details of one thing we did, which was addressing the opioid policy. That's just one example. I'm sure there are lots of other things out there that equally need attention. But this lack of knowledge and understanding is one of the things that really struck me. We honestly don't know what we don't know. And I think most of us want to help, but we need information. So we've talked about all the barriers that occur. I'm going to talk about compartmentalization in a minute. I think we have an opportunity to educate providers if they're missing information. I think most of them, if they knew, the thing that I can't understand really is that a simple blood smear is all you need to tell whether a person is having a sickling crisis. And apparently that's not being done. We've talked about formularies and prior authorization. We need to work on identifying barriers and helping to remove those. One thing I have not heard mentioned is Premera has, we in addition to being in Seattle and Washington State, we also are Blue Cross Blue Shield of Alaska, which has more empty space than any other state in the country. And so people who live substantial distances from where they're getting their care, and I'm guessing that sickle cell folks, a lot of them probably, I've heard other rare disease patients say, I feel like I'm sort of tethered to my healthcare facility. It's like I can't go very far away from there. That's a barrier. So next slide, please. So I think we're dealing with a certain amount of unconscious bias, and this is insidious because it's in the air you breathe. You don't think about it, but it blinds people to seeing things like what I've just been describing. And I think that we need to work as individuals on understanding better. So who needs to know more about SCD? Well, clearly the Pharmacy and Therapeutics Committee members, we've done education with our committee. They may be tired of hearing me talk about it. Network providers, I've already touched on. We need to make sure our staff at a number of different places within the company know that. And the employers, I'm speaking for the commercial side. Yes, the majority of these patients are Medicaid, but we happen to have one very large employer, custom client, who is in all 50 states and has a number of these folks on their plan. The people that deal on that interface, we have some pharmacists that consult with employer clients. And what they want me to do is give us a story we can tell the client as to what the value for them is. So clients don't know these things. They are not aware of the impact that some of their benefit decisions have. And here, this is where the compartmentalization comes in. We talked about lack of dental coverage earlier. This insurance system is over 100 years old, and the people that put it together apparently never stopped to think that your dental health has a lot to do with the rest of your health, because if you can't eat properly, you're not going to be in good health. And there also are some diseases that you can get through the mouth if you have bad things happening there. The employers and the consultants that they work with when they choose a health plan seem to like to carve out benefits. So John talked about the issue with state Medicaid plans where you may have an entirely different pharmacy benefit. We have employers, and it so happens that the employer that I was talking about has carved out pharmacy. So we only have the medical coverage for them, and that limits what we can do in that space. So that's something that needs to be addressed. Next slide, please. I think you've heard enough about what we do at Premera, so I'll pass by that part. We need to make sure that not only are there minimal prior authorizations, but I was a little bit surprised to see that many plans require reauthorization every 3 months. And if you qualify for this, it's not going to suddenly stop working in 3 months. So what I'm more used to seeing is a once a year check-in, and with something like this, it should be just a matter of if it's still working, yes, off you go for another year. A lot of providers will not give us the information that we ask for, and I know that Premera does work very hard to make that information publicly available and very clear as to what the pharmacists that do those reviews want to see. So that's an encouragement to providers. I know it's a lot of work, but take a look at that and see if you can give us what we ask for. I think most people that I know in managed care pharmacy are not going to hassle you if you just provide the information. Next slide, please. Reasonable criteria, I think we've addressed that. Having a whole bunch of step edits doesn't make sense. But I think realistically in the commercial space, remember that these are employer-sponsored plans, most of them, and most employers are going to want to see that you step through hydroxyurea. It's inexpensive, it's generic. That's a fairly standard thing. It should be a pretty low barrier. Plans like Premera actually oftentimes will have, if you have the pharmacy benefit coverage, you can put a look back in the system that when a prescription for one of the other drugs, say Andari, comes through, the system will automatically look back and see that, okay, you have prescriptions for hydroxyurea. That happens in a fraction of a second, and you'll never even know that it happened. The prescription then just doesn't stop. So more of that kind of automation of things, and more as we get better in terms of connectivity with providers, to be able to have criteria electronically available at the prescribing point. That technology has been around for some time. It's a matter of interoperability of systems if it's not happening. Overall, part of the problem is just that drugs and healthcare in general cost so much. And in these discussions, nobody seems to ever ask, why do they really have to cost as much as they do? I was just listening to a podcast a couple of days ago, and they pointed out, they were talking about the student loan forgiveness and the fact that there are three things in our economy that a lot of people get that have inflated in cost way above the background rate of inflation. And they are healthcare, housing, and higher education. They all happen to start with H's. But why can we not get some of these things to be a little bit less expensive? And with that, I will wait for the Q&A, and you can ask me whatever you like. Thank you.
Thank you so much, John. We'll go ahead and move right into the last presenter. So Chanel, go ahead and take over.
Thank you, Emma. I hope everyone can hear me okay. Thank you to both of the previous presenters. Those were excellent presentations. It gave a lot of information. I am Chanel Grismore. I am the director of the Sickle Cell Center. I'm going to be speaking to you from the perspective of someone that has come into a large academic healthcare system to set up infrastructure for specialty care around the sickle cell population. So next slide. So this is California. This is where I am. I'm located in Loma Linda, California, and I've highlighted on the map. So this image gives you an overview of the number of patients with sickle cell throughout the state of California. But I've highlighted the counties that have some of the higher numbers. And you'll see Los Angeles County has the highest population of individuals with sickle cell. But where I am, which is San Bernardino and Riverside County, so at Loma Linda, we serve both counties. We call it the Inland Empire or Inland Region. We have the second largest population of individuals with sickle cell disease in the state. And so we took on an initiative to develop an adult sickle cell center at Loma Linda. We are in our infancy of developing this center. We opened clinic in November of last year. And it has been an interesting experience since we've started, and I'll share a little more about that in the next couple of slides. Can you go to the next slide, please? So we are funded through a state grant from AB 1105. This was a state grant that was given in 2019 or introduced in 2019. And appropriated about $15 million from the state general fund to establish a 3-year program for pilot adult sickle cell disease centers. And we received a portion of those monies, and that grant is subsidizing a portion of cost for our sickle cell center here at Loma Linda. And some of the pieces of care that we're focusing on, and I'll again describe in later slides, is a comprehensive outpatient care model with behavioral health, social support, team-based sickle cell specialists that can provide care for this community. The model we utilize is the medical home model. And this is where we can bring in a number of different services into the sickle cell center. So patients within our sickle cell center have access to all of these services. So behavioral health, infusion, pain management, social support in the form of a social worker that's in clinic or follows up with them, a personalized sickle cell care plan. We're going to start rolling those out, medication management, and coordinated care. Next slide, please. Okay, and then so for some of the program components that we have, I'll describe the clinical care piece first. It's our clinic is, again, in its infancy. So we're operating at 2 half days a month right now, but we're working to transition to a weekly clinic by the end of this year, perhaps sooner. And we have sickle cell specialists. We have a pain management specialist. So when I say pain management, we have a palliative care provider that is focused just on managing the pain management for our patients and developing pain treatment plans, mostly around prescription medications that are appropriate for each patient. And this approach is individualized. We have a social worker that's in clinic as well, and she does a wonderful job at delivering social determinants of health support. Once we transition to our weekly clinic, we'll actually take a much stronger, more proactive approach in doing the social determinants of health screening around looking at housing, transportation, financial assistance. All of those services we currently offer through our sickle cell center. The assessments that we'll be doing with the social determinants of health are to further inform us of any additional needs for our patient population. Behavioral health, as I mentioned, is part of our sickle cell center as well. We do connect patients to external and internal resources, and we will be bringing in special diagnostic testing specific to our patient sickle cell patient population. And I'll describe that in later slides. Education is a word that's been used very frequently throughout the presentations and the sessions today. So we are working on getting education rolled out across our health system. So we are looking at doing nursing education, which will actually start in September in time for Sickle Cell Awareness Month. We thought that'd be a perfect opportunity and a perfect way to raise awareness about the month and educate the nursing team. And that would be our inpatient and our outpatient nursing team. We also have family medicine residents and palliative care fellows that rotate through our sickle cell center, and they work with the attendings in that clinic to learn more about sickle cell and how to better care for patients with sickle cell disease. Next slide, please. So social support, again, is looking at those social determinants of health. And we have a social worker that really works with us on getting these pieces addressed for our patients. So we provide transportation through our center. We provide food. We have a food pantry for patients where we can provide food for them when they come to their clinic visits or if they need to come and pick up food on another day. We work with different local CBOs to get them financial assistance if needed, as well as housing assistance, insurance and benefits navigation. I'll say insurance is one of the biggest barriers for our patients in accessing care. And so our social worker has been really helpful in making sure our patients understand what insurance they have, what insurance they need to get access to this specialty care. And it's been a learning experience for our entire team and a lot of times for patients and their families as well. We also have a support group. We have a support group that meets every month, and we have peer support groups for our younger patients that are transitioning from pediatric care into adult care. And we have a number of different community engagement pieces that we are working on right now. I guess the benefit of us being so new is that we get to really build this with the community. And so that's the approach we're taking in terms of building out this Sickle Cell Center at Loma Linda. And so we've just wrapped up a year-long needs assessment that we conducted among patients, advocates, providers, and we included our payer. Our major payer out here is IHP, Inland Empire Health Plan. We included them in the needs assessment. And we did interviews and focus groups to better understand some of the barriers and the challenges patients have to care, some of the barriers and challenges payers have in terms of supporting that comprehensive care, and also some of the barriers and challenges providers have in supporting that comprehensive care. It was really important for us to include the payer into that needs assessment because it was our opportunity to actually provide education as well as understand a little bit more of how we can collaborate in the future. And I'll talk about one of those collaborations on the next slide. So one of the collaborations we did with our payer is IEHP is a modified prior authorization process. And that is, prior authorization is a huge barrier when we're trying to get patients into timely care, specifically around infusions. And when I say infusions, I'm talking about things like IV pain meds, IV fluids, simple transfusions. And so we worked with our payer to get a retro or advanced prior authorization process in place. That way our patients could get access to same day infusions. Instead of waiting for prior authorizations, they could get the treatment then. Other opportunities to improve access would include having value-based payment incentives for institutions that are providing comprehensive care to this population, and having a multi-government agency and funding network. This is modeled by hemophilia, which has a third of the number of individuals living with hemophilia as sickle cell does. But they do have a multi-government agency funding network with a lot of these different agencies I've listed down here, such as the Public Health Services, HRSA, CDC, and NIH. Next slide. Okay, and that's my last slide. So thank you, and I invite any of your questions.
Thank you so much, Chanel. I will go ahead and bow out, hand it off to Adrian to lead the moderated Q&A.
That was such an amazing panel, and as the sister of a weaned warrior, and the mother of a sickle cell warrior, and the mother of a trait carrier, the information here is so timely, and it's just so rich. So we're going to get quickly to a couple of questions. So we've been hearing about so much about prior authorizations, and it was something that we've fought against, however you want to call it, for now the last at least 40 years of my life, but particularly when we got new treatments. So Chanel, you already talked a little bit about what your experience was in that realm. So how did you approach getting these modified PAs, and did they include things as well as the new treatments?
So yeah, to your latter question, yes, those are included. For the approach, so it actually started with an educational approach. I approached the medical director over care coordination at IEHP, and she had been working on a couple of pieces around sickle cell disease. But the way I approached her was simply, we have these patients that are coming through the ED and urgent care to get things like IV pain meds and IV fluids. Why not make a more streamlined process so that they're not sitting in the ED or the ER for hours? Because as you know, even minutes matter when you're in a crisis and you need fluids or pain meds. So let's make a more streamlined process so these patients can go to an outpatient infusion center and get their infusion treatments. And so it actually began with educating her as to, kind of why that would be the best approach and why that would make sense. And then she worked with me to get that modified prior authorization process in play for our patients with sickle cell. And it has been, hands down, has been one of the biggest task I've taken on since I've started kind of implementing the center. And it has been one of the biggest payoffs in terms of getting our patients access to care. And I think I answered your latter one, that it does include those other drugs as well. But typically with like the Oxbryta or Adakveo would be the only infusion one most of our patients utilize. Typically, those are scheduled out, so they don't need the same day infusions. But for IV pain meds and fluids, those do need same day.
That is great. And I think that's something we're all taking notes and going to add to our playbooks. So thank you. Education is something else that keeps coming up. So we in the community, we spend a lot of time educating our warriors, educating our advocates, a lot of times educating at the point of care. So it's very interesting when I hear you as payers from that standpoint saying that you see the need for more education. And so what will you think of if we wanted to be involved, or how can we help? What would be your top 2 things that we as a community could be doing in order to support that education? And I was going to say we're going to start with John, but we've got 2 Johns. So, okay, we're going to take John Watkins.
Yes. I talked about that quite a bit.
You did.
And yeah, I think, I was really excited about this, as I said, in the beginning of 2020, and then this little pandemic hit, and it's kind of shut everything down. So we're picking up the pieces again, but I think this is something that could be explored with payers that are interested. One of the current trends that everybody is doing is jumping on the DEI bandwagon. And so if you want to do something more than just pay lip service to health equity, here's something that you can actually do that would make a difference. There's also, with the providers, Chanel, what you were talking about, payers have what in the jargon we call gold carding providers. So that's an agreement with specific providers that we're going to trust you. We know you know what you're doing. We'll review your utilization maybe at the end of the year, and as long as it looks reasonable, then we renew that status. And the prior auths for certain specific things go away in that environment.
That's great. Okay, John. John S.
You couldn't even say John with the beard, could you?
No, that's very funny.
Nope.
I could try glasses, but then,
The reality is that these new therapies do come at a cost, so there is going to be prior authorization. But similar to what Chanel talked about and how their approach, I think it begins with collaboration. And everyone has a different perspective. Everyone has a different approach. Everyone has a different agenda that they have to kind of adhere to from the role that they have at their organization. And so I think that is important. But as to what Dr. Watkins was saying, is that in the North Carolina Medicaid agency, we didn't have an expert hematologist on staff anywhere. We had a medical director that came from a primary care setting. And most of our P&T, there would be a handful or a few specialists, but it was usually pediatrics, behavioral health or psychiatry, those type areas where there was obviously a greater population of patients or a greater spend, that we wanted to make sure we had expert opinion. And so I think it's important that, and there's some very passionate sickle cell providers out there, that they share their expertise and make sure they're there as a educational partner for that payer, not in an adversarial or hard-nosed approach, but we want to partner with you. And the thing that I would encourage Chanel is that please publish this work you're doing, because again, it could be a model that other people would take forward. I know there's these ECHO programs where different universities across the country share ideas and things that have worked for them. I would encourage you to participate or even create your own there. But again, put the treatment experts in front of that payer to help educate that payer. And then I think that payer will feel a lot more comfortable that you're going to use the drugs appropriately, and they will begin to relax restrictions or create greater access.
Wow. That is so much knowledge. And what I love is it's not just knowledge, it's instructions. We have our marching orders. So I want to thank you, Chanel. I want to thank you, John W. And I want to thank you, John S. And I'm going to turn this over to Ashley. If you have any questions, please put them in the chat. We're going to make sure that we get those questions answered. And I have to say that this has been one of the most fruitful conversations that I have had in a long time. And many of you know I'm in on a lot of meetings. So this is where we are, and this is what we have to do. We're blessed to be here. We're in a difficult time, but 125 years of nothing to suddenly be where we are, where we have all these choices, and now it's just figuring out how to get it. So once again, I thank you, and I'm going to turn it over to Ashley.
There she is. Thank you, everyone. What a wonderful day. It's been an educational day. We got through a lot in these 4 hours. We opened this morning with a discussion with Dr. Amar Zaidi, where he recounted what he saw in the clinics when he treated over 800 sickle cell disease patients in Michigan. And he noted that by no fault of their own, people with sickle cell disease and their families are drowning. But there's hope and opportunity to change this through empathetic care. We also learned from Emma Endelson about the state of access in Medicaid for prescription drugs treating sickle cell disease. That full report is available on the Sickle Cell's website. Afterwards, Terry Richardson from IDPAC Education hosted a CME accredited session. This session welcomed my mom and Marcus's mom, Francesca Valentine, who took us through what delays in care and access look like on the family and talked about real-world barriers. We also heard from Dr. Terry Cothran and Emily Sau, who discussed the payer perspective on how to close the treatment gap. We learned about the pathology and physiology of sickle cell disease from Dr. Jane, who is a provider who treats adults living with sickle cell disease. The real-world implications of barriers to accessing care were illustrated by a dynamic panel of sickle cell disease warriors and caregivers. We learned from Ray Blaylark, Chiffon Powell, Blaze Eppinger, and this panel was moderated by Christina Reed. They discuss how new treatments can provide job stability and dignity to someone living with sickle cell disease. We also learned about the emotional and mental health impacts of sickle cell disease. Finally, this last panel, we learned from John Stansel and John Watkins about a managed care approach from the public and commercial payer perspective. We also learned from Chanel Grismore what coverage means for a new sickle cell disease clinic. This discussion was moderated by Adrienne Shapiro, a sister of a winged warrior and a mother of a sickle cell disease warrior. So during all this entire day, I was writing down words and phrases and opportunities that resonated with me. And the big takeaway is we're in a renaissance moment for sickle cell disease. The sickle cell disease community received our first new approval for a treatment in 2017 and then 2 major approvals in 2019. The reality is, shortly after our 2019 approval, the world went into a public health crisis and the focus shifted away from sickle cell to combating the COVID-19 pandemic. Now that we're learning to live with COVID-19, it's time to refocus and harness this opportunity to educate about the importance of robust coverage for sickle cell disease and exactly how to do that. There will be a readout later this year from this meeting. If you'd like to stay engaged, please sign up for our newsletter and follow us on all of our social medias and our LinkedIn page. Also, if you're inspired to advocate or to learn more about advocacy, join our ambassador program. We have many other opportunities to learn about the sickle cell disease community through storytelling across our website, and we also have materials available in Spanish. So I thank you all again today, and a special thank you to Maggie Jalowski for organizing this event, for Abby Tainer and Corey Lewis for running the tech support, for Emma Endelson for presenting today and moderating, and to all of you for joining us and taking interest in sickle cell disease.